ഞാൻ യൂട്യൂബിൽ ചെക്ക് ചെയ്യണ്ടായിരുന്നില്ല.
Mute. Is the audio on?
Yeah, the audio is on.
Professor Faiz,
Please unmute.
you're muted. Please unmute yourself.
No, I'm unmuted now.
Okay. How is the snakebite situation there? Are the cases more after COVID or less?
You know, during COVID, the reporting, the recording from the different hospitals, they declined. In comparison to last year, we get information from at least some big hospitals. The case number reduced to almost half, but death rate in some hospitals increased. And there are some deaths in the community. You know, we had bad flood this year from June to September. And during this period, only during this period, several districts, there is an emergency response system for floods. So they recorded 92 cases of snake bites with 32 deaths.
Oh,
This is very big in comparison to previous floods. So this is most likely due to that patients could not come to hospitals, and the hospitals are concentrating on COVID. So non-COVID patients suffered a lot. I think this ranges from many conditions, including our pivotal area of interest, the snake bite.
and is snakebite notifiable as of now in Bangladesh?
Not yet, not yet. We are trying hard. We are trying to develop this strategy with a costed action plan. Unless we have this costed action plan, and unless we have got a strategy, then people won't. And there are many other conditions which are notifiable. For example, we have got Infectious Disease Act, by which this TB is notifiable for the last 4 years or 5 years, but people are not notifying. So even if it is notifiable, unless there is a strong regulation, then possibly it won't mean anything.
Given your reach in the, I mean, as a previous director of health services, if you should be able to push it through, no, people would listen when you speak.
Yes, we are trying almost on regular basis. We have connections with ministry, with minister, with DG, with secretary, but you know, considering so many problems, it cannot get due attention because they have got many problems to solve. So snakebite is not on the radar, but sometimes it come in the forefront, like during floods and during this International Snakebite Awareness Day. Before and after that, we try to hold several meetings. So this year we had several meetings, but particularly training through this Zoom link. We connected almost all districts, sub-districts for mitigation, management. You know, unless there is community program, you cannot do any head-on in snake bite.
Surajit Giri, please wait. This meeting host will let you in.
Dr. Surajit Giri is in. Mohammed Anwar is in.
Okay. Our speakers, put them into the box.
Yeah, already.
So David Ward?
No, not yet.
Not yet. And Tarun Sharma? Vishal Santra. It's two. How many have come in?
80.
I think we'll start. Yeah.
I'm getting everybody. You can give a small intro.
Why don't you start? It's about 2 o'clock Indian Standard Time, and I think it's important that we keep time. Sorry for keeping ourselves masked. I mean, my ugly face is better covered, but this handsome gentleman on my right is much better looking without a mask. Can you all hear me?
And they cannot reply back.
Yes, I hear.
Okay. So what we'll do is we start at 2 itself. We have about 80 or 90 people who already have logged in, and we start with Professor M. Abul Faiz, who is a senior physician from the country of Bangladesh. He's been a regular in quite a number of our conferences, a big name in the field of snakebite, especially in the subcontinent, and somebody that the whole of Bangladesh falls back on regarding this and other tropical diseases. Dr. Abul Faiz retired as the Director of Health Services in Bangladesh, and he continues to serve his people from Dhaka. Can I now invite Professor Faiz to deliver his lecture? And this is to remind you that the talk is for 15 minutes and followed up with 5 minutes of discussion over the chat box. The questions will be asked by us to Dr. Faiz, who would answer. Over to you, Professor Faiz. All the very best.
Thank you very much. Am I audible, please?
Yes, sir. Perfectly, sir.
Thank you. This is indeed a great honor for me to be here to talk online in the annual Snakebite Conference 2020. It's a very prestigious conference amidst very distinguished colleagues, distinguished audience, and distinguished speakers. I would like to concentrate on next few minutes on snakebite in Bangladesh, what we are doing, and what is the way ahead. Next, please. You know, Bangladesh has got next, please. You know, Bangladesh has a very rich fauna on poisonous snakes and diverse. There are a couple of types of Naya, Bokro, and there are at least 5 varieties of crates, including new black crate, 4 varieties of green peat viper, besides Russell's viper and sea snake in the country. Next, please. You know, the snake bite as a public health problem, it is a big hidden problem. And you know, about 10 years before, we had a big community-based survey which estimated around 700,000 episodes with more than 6,000 deaths a year. This year, only in 3 to 4 months' time, there are 92 bites have been recorded during floods with 32 deaths. Next, please. You know, the health services in Bangladesh, public health services spread across the whole country. The red box is a sub-district hospital, and the green box is the smallest facilities close to the community, called community clinic, serving around 6,000 population. You know, the multi-sectoral approach is yet to be significantly visible in Bangladesh, like our neighboring countries. The snakebite treatment was on the helm of the traditional healers, Oja, in the past. But currently, fortunately, there is shifting towards scientific treatment. Next, please. Then diagnosis of snakebite is mostly on clinical syndromes I'm talking about the distinguishing various types of venomous bite, besides the distinguishing from the non-venomous and venomous. There was little attempt in the small hospitals in species identification by the specimen brought by the patients, around 10% subjects being the specimen, but people are not very keen to see those specimens. The associated investigations, bedside test, 20-minute WBC is practiced. There are few tests used in the small hospitals. Still, we do not have the capacity or do not use the antigen-based immunodiagnosis for point-of-care diagnosis. But I like to have a comparison here that the expert for TB diagnosis is available at the sub-district level, as I mentioned earlier. And the RT-PCR for COVID diagnosis is available in more than 115 sites. Next, please. You know, the antivenom is yet to be produced in Bangladesh. We use either imported or packaged antivenom from Indian source. Of course, the different species, then what are the venomous species here? The early antivenom reactions is, a problem for wide use, but present guideline recommends prophylactic adrenaline. But still, doctors are scary of using antivenom at sub-district level. It is very nice to know that a recent shift has been found in the attitude of the physicians working in sub-district hospital, which is quite encouraging. There is no antivenom available for green pea viper or sea snake bites. Next, please. The treatment close to the community, it is preferred. We have got around 490 plus sub-district hospitals. Few have started using antivenom. And unfortunately, the continuity of supply of antivenom and logistics is a big issue. We are trying to link the medical colleges with the small hospitals, where most of the cases can be managed. And we have seen that in some of the hospitals, which is quite economically saving. For cobra bite, in addition to antivenom, the new and atropine for this type of bite is not very popular. Supported treatment like respiratory support using intubation and ambubec, and particularly during transfer to higher up, we have to go a long way. Next, please. The first aid that we teach in schools, they have got some errors we have identified and we requested for revision. The community education on first aid is necessary, and various types of IEC materials have been provided. Immobilization or pressure immobilization is improving slowly. Initially there were very few, but now it is around 12%. Next, please. These are some of the examples that for IEC as well as the school textbook, which we have recommended for changing. And the next, please. Currently there is no routine surveillance system for snakebite, so data is very patchy and from few institutions. Outcome is widely variable. You see that we have got a 24/7 snakebite clinic in one medical college hospital called Chattogram Medical College, who used to deal around 1,000 cases a year. Actually, no death, zero death for the last couple of years. On the other side, some of the hospitals, medical colleges, there are half the cases, but 40 to 50 deaths per year. We are trying to replicate the snakebite clinic through policy advocacy, which is ongoing. Next, please. The comprehensive care, which is very essential, is emerging. For example, we have started changing the attitude of the colleagues from fasciotomy to reconstructive surgery. In this slide, we see that this cobra patient, he was a snake catcher. He underwent the reconstructive surgery and he was in ventilation for about a week. So we have our support from manual to mechanical ventilation is increasing. So also for AKI from observation to hemodialysis. Next, and for next, please. The post-acute care and follow-up still not widely used. There are physical disabilities that are reported, contracture, amputation, but extent is not really known, but around 10% patients, they have got this type of disabilities. We really don't know what is the psychological morbidity, like post-traumatic stress disorder, which has been found in Sri Lanka, the effects of neurocognition, following neurotoxic snake bite, particularly in children and adolescents requiring respiratory support. I think this is a very important area to understand. Next, please. The community engagement, empowering the people and communities. We are trying to improve the early treatment seeking by quick transfer to the facilities, providing appropriate first aid. The preventive methods like very popular using cot and net, the separating food storage and poultry from human dwelling, and avoiding wood and stone piling, safe garden watch and safe fishing, improved housing as a part of NTD elimination. But we have to go a long way for which are the effective one. And support from the community-based healthcare from the community health workers, particularly the multi-purpose health volunteers, we are trying hard. Next, please. Our colleagues working in community-based healthcare, she was identified as one champion of snakebite this year by our learned professionals because of her involvement. She's very ambitious. She's trying to train the community health workers in the community-based support from around 100 sub-districts. So around 500 these multi-purpose health volunteers will be trained on snakebite prevention and early referral in this year, only trying to improve that. Next, please. The Venom Research Center that has started in Chattogram Medical College, they are already started. They have started the snake rearing and venom collection, and the collaboration has been started. We already had some preliminary venom analysis and neutralization assay. We have the target of using this identified venom from Bangladesh for production of antivenom as a demonstration project. The guidelines and training manuals, they are developed, but not enough because the standardized methods requiring for clinical diagnosis, treatment, recovery and rehabilitation, prevention, these we need to develop collectively in our region. Next, please. The Toxicology Society of Bangladesh is assisting the government for human resource development, but the team-based care is not enough. We also think that this acquisition of competency related to this snakebite management, providing support, first aid, we need to teach the healthcare professionals and also improve first aid through the school education, and community engagement should be a pivotal force. Next, please. The snakebite strategy and cost reduction plan, we have started the initiative and through lobbying, and snakebite is still not a notifiable disease. We like to have this strategy through utilizing these important pillars that have been recommended by the World Health Organization. The snakebite strategy for prevention and control, targeting 50% reduction of morbidity and mortality by 2030 through pillars of care, health system strengthening, prevention, community engagement, collaboration, and research. Next, please. I must thank my colleagues who are doing a tremendous amount of laudable job across the country, including the Venom Research Center and our colleagues from various laboratories working in the universities. Next, please. If I conclude, Honorable Chair and distinguished colleagues, that the WHO provided this emergency care system. There are at least 4 groups of emergency care, starting from cardiovascular diseases, the maternal health related, the infection related, and injuries. The snakebite is under the category of injuries. So we need to do a lot, starting from scene to facilities and transport. I think the snakebite management should be a model for providing emergency care, because this is one of the most low-hanging fruits for providing emergency care. So if you can succeed in providing emergency care of snakebite management, starting from community and transport to the facilities and emergency care at the emergency room and referring and in the hospital indoor, and then if necessary providing other organ support and long-term or security management. And I think if we can demonstrate that snakebite can be managed effectively, possibly we can strengthen our health system, the emergency health system in particular. So I'd like to thank you very much indeed for your very kind attention, and thank you very much indeed. Good afternoon. And
thank you, sir. You kept perfectly to time, and you've given us a broad overview of the situation in Bangladesh. and with some very relevant points which are relevant to the whole of the tropical, to other tropical countries as well. And there are a couple of questions. Can I ask you those, sir? One is from Dr. George Paul. He wants to know as to how one would diagnose snakebite cases other than from clinical features, which sometimes are confusing. Do you have access to immunoassay anywhere, say in forensic labs?
Thank you very much, Dr. Menon, for your excellent question. Currently, our colleagues in different hospitals, starting from community to medical college hospitals, we do not have any specific methods or a specific immunoassay for diagnosis of antigen, either taking sample from bite site or from urine or from serum. But rarely they used to collect specimen for doing some forensic purpose, but this is not routine. The patients are not being, there are some not getting benefit, but there are some research studies which were done in recent years, but they are retrospective. So, we have collected the samples and we did the study. The sensitivity is not quite good, but this is quite relevant that we should strive for have a rapid diagnostic test, immunodiagnostic test. That's what I refer to, these antigen tests or RT-PCR for COVID and TB, MDR TB. These are available, but why don't we have these immunodiagnostic tests available for the patient in the bedside? I think this should be one of the topmost agenda for us collectively.
There's another one question on the chat box asking, are there sources for recognition of snake bites?
Pardon?
He wants to know whether there are any sources for recognition of snake bites, kind of signs and symptoms for the recognition of snake bite.
In Bangladesh, most of the snakes, as I mentioned in the very beginning, there are mostly neurotoxic or having action on the coagulation system. So most of the patients which are venomous, they come with early features of bilateral ptosis of different types, difficulty in talking, this diplopia, weakness of the limbs, broken neck sign, and the respiratory distress, cyanosis, and depressed reflexes. So this, along with or without swelling at the bite side, one can distinguish cobra from crate. And if there is swelling, most likely cobra. If there is no swelling, then most likely crate. And for the vipers, Russell's viper or green pit viper, they do not have any neurotoxic feature, but local swelling and progressively increasing swelling and prolonged bleeding. So 20-minute WBCT is quite relevant in distinguishing viper from the neurotoxic, and also the Russell's viper, which are prevalent on the western part of Bangladesh, emerged as a problem. So there is progressively increasing swelling, prolonged bleeding, 20-minute WBCT positive, urine albuminuria, raised creatinine, and this leukocytosis are all this. Through this we can distinguish from cobra, from crate, from Russell's viper, from green pit viper. So I think most of the clinicians, they should be able to identify at even in the sub-district level, the potential types of the venomous snake. And again, they should also try to have a look into the snake. 1 in 10 patients, they used to bring the snake, sometimes dead, sometimes living. So I think in the medical curriculum, the doctor should be able to identify this different type of snake. We try to distinguish very rare diseases by doing so many investigations, so many tests, but hardly we teach how to distinguish one snake from the other. They think that possibly this is the subject of forensic medicine and toxicology, not the clinician. So clinicians should have this skill as well.
Thank you, sir. Excellent talk as usual. Keep the interest going for the cause of the victims of snakebite, especially in the tropics. Thanks so much, sir.
Pleasure. Thank you.
We move on to the next topic. The next session is
the topic is evolution bites. Why India needs a much improved snakebite therapy. The speaker is Karthik Sunagar. He's from Center for Ecological Studies, Indian Institute of Science, Bangalore. Has taken PhD from University of Porto, Portugal, and guest scientist at Hebrew University of Jerusalem, Israel. and welcome Trust India Alliance Fellow. Respected sir, please present your topic. Your topic time duration is 15 minutes, and we have 5 minutes discussion. So I hope that it will be a good session for all the participants. Its topic name again I'll announce. It's evolution of bites. Why India needs a much improved snakebite therapy. Welcome, sir.
Thank you so much for the introduction. I hope you can hear me clearly and see my screen.
Yeah.
Okay, great. Hi everyone, very good afternoon. This is Karthik Sungar from Center for Ecological Sciences, Indian Institute of Science. I head the Evolutionary Venomics Lab, and today I'll tell you why India needs much improved snakebite therapy. As you all know, India suffers the brunt of snakebite in the world. Over 56,000 people die every single year. And in addition to that, at least 3 times that number suffer permanent disabilities, disfigurements, and amputations. So snakebite in India has a huge socio-economic impact. As you know, snake bites are treated using antivenoms, which are produced by collecting venoms from the snake against which the antivenom needs to be made. This is then injected into horses in sublethal and subtoxic doses. The resultant antibodies are harvested, purified, and sold as antivenom. Studies, including some of our own, have shown that distinct geographic populations of the same species of snake can have very different venom profiles. So, for example, in this species of rattlesnake that we looked at, one of the population was highly neurotoxic, whereas others were highly hemotoxic. So, if one were to make antivenoms using the hemotoxic population, then obviously it will not contain any antibodies against the neurotoxins. Ignoring the geographic variability in snake venoms, we produce our polyvalent antivenom using venoms from a single population in the southern part of the country. This is not the antivenom manufacturer's fault. This is only a venom that's available to them. In India, we also make antivenoms against the so-called big four snakes, which includes the spectacled cobra, the naja naja, Russell's viper, Daboia russelli, common crate, Bungarus ceruleus, and the saw-scaled viper, or Echis carinatus. But there are many other medically important snakes in the country with relatively limited geographic distribution. And last year around this time, we showed that the Indian polyvalent antivenom is not really good at neutralizing envenomations from many of these snakes. So what about the neutralizing capabilities of these antivenoms against our big four snakes? So today in this talk, I'll give you some of the work that we have been doing in the lab, one on naja naja and the other one on Russell's viper. In the interest of time, I'll mostly focus on the results of naja naja. So snake venom research in India basically started with this landmark paper from Professor Gowda's lab in the University of Mysore, where they collected venoms of Russell's viper from 3 distinct locations and subjected them to chromatography and saw variations, regional variations in venom profiles. Since then, many studies have taken place characterizing the venoms of medically important snakes, but a comprehensive analysis of venom compositions and potencies has been lacking. And we also lack the understanding of the influence of biogeography on Indian snake venoms. So if you look at the preclinical effectiveness of Indian antivenoms, again, very limited studies have looked at it in animal experiments. Many studies have indeed looked at the binding efficacies, but as you know, binding does not necessarily reflect on neutralization because the antibodies present in the antivenom may bind to the snake venom toxins, but they may not neutralize the toxic symptoms. So this becomes important to test these in an animal system such as the murine model. Some studies that have taken place on looking at this have followed protocols that deviate from those recommended by WHO. So they are not comparable to each other. You can't even compare them to the outcomes reported by commercial antivenom manufacturers. So to address this knowledge gap, we collected venoms from various locations across the Indian subcontinent, from various biogeographic zones, starting from the coastal plains to the Western Ghats, the deserts, the semi-arid regions, the Deccan Plateau, as well as the Gangetic Plains. We collected venoms from over 128 individual snakes of naja and Daboia, and then we subjected them to in-depth proteomic, biochemical, and pharmacological assessments. Then we also looked at the influence of distinct biogeographies on the toxicity profiles of these snakes and the consequent repercussions on the effectiveness of a commercial antivenom. So basically, these two come from these 2 papers that are currently under review. Before I start my talk, I would like to say that the 2 projects were largely contributed by Senji, Suyog, and Saurabh from my lab, who were assisted by Vivek and Ashwin. And it also involved some wonderful collaborators in the form of Nick, Jerry, and Ron. So firstly, let's look at the influence of distinct biogeographies on the compositions of venoms. So here I have shown RPHPLC profiles of venoms of cobras from 7 distinct locations across the country. Each peak here is uniquely color-coded. It may contain multiple toxin types. But if you just focus on peak number 4, which we found to be enriched in a form of 3-finger toxin called neurotoxic 3-finger toxin. Basically, this is responsible for all the neurotoxic symptoms that are seen in cobra envenomations. You will see that the area differs drastically between populations. Some populations have really large amounts of this toxin, and others have very limited amounts of it. Similarly, a lot of differences were also seen in the pan-Indian populations of Brussels viper. So we wanted to understand what are these components that are changing between the populations. So we subjected each of those fractions to tandem mass spectrometry, which revealed that the venoms of some populations, like the Eastern and North Indian populations, are almost entirely composed of neurotoxic 3-finger toxins, which is indicated by this blue color here. Whereas some other populations, like the desert population, they have large amounts of cytotoxins or cardiotoxins. So they basically bind to the cardiac muscle and cause cardiac arrest. A lot of differences were also seen in different populations of Brussels viper, basically variations in phospholipase A2s, in QNITs, in serine proteases, and C-type lectins were observed. So now that we know that the venoms vary in terms of their composition, as well as biochemical and pharmacological effects, which I have not shown, we wanted to see what are the effects of these biogeographies on the potencies of venoms. As you know, snake venom composition and potency is largely driven by the ecology of the snake, basically on what they eat. Last year, we showed that the venom of this banded crate, which is a snake specialist, that is, it feeds mostly on other reptiles, has very least potent venom against mammals compared to all other snakes in the Indian subcontinent. So we performed these experiments in the mouse model where different concentrations of venoms are injected to figure out the amount of venom required to kill 50% of the test population using statistics. As you can see, the populations that had really large amounts of neurotoxins were also some of the most potent ones. Whereas the Rajasthan or the desert population, for some reason, was least potent. And this also shows that it also highlights the importance of neurotoxic 3-finger toxins in the ecology of these snakes. A lot of differences were again observed in distinct populations of Brussels vipers, with the North Indian as well as the Central Indian populations being some of the most potent ones. By the way, this also probably indicates that the Rajasthan population perhaps feeds on a lot of other things than mammals. Now let's look at the repercussions of all this variation that we saw on the efficacies of Indian antivenoms. So firstly, we performed venom recognition experiments where on plates, the plates are coated with different venoms. Here, 7 different venoms from 7 different populations of cobras. And then various dilutions of antivenoms are added. So we tested all the major antivenoms that are widely used in the country. And then you measure absorbance. We also add naive IgGs from naive horses, which are never immunized with venom. So you don't expect them to bind. So this is used for calculating the background binding. So basically what you see is blue color here. It illustrates strong binding, whereas a reddish to brown color indicates least venom recognition potential. And as you can see, premium serums performs relatively better than all other antivenoms that we tested in the study, immediately followed by Vince, but these two didn't perform so well. And very similar results are also seen against the pan-Indian populations of Brussels viper, with premium serums performing relatively better than all other antivenoms, especially the last two, especially compared to these two antivenoms. What this tells us is that it's very unlikely that these two antivenoms are going to have a lot of neutralizing antibodies because they already lack binding antibodies. But this does not necessarily indicate that premium serums probably works better than all others, because binding antibodies, like I said, may not necessarily reflect on neutralization. So the only way to look at the preclinical effectiveness of antivenoms is by performing something called ED50 experiment, where you take where you take at least 5 times the LD50 of the venom, and mix it with various dilutions of antivenom. And then this venom antivenom mixture is administered into different groups of mice. And then using statistics, you can calculate the neutralizing potential. So here in this graph, I have indicated the marketed neutralizing potency in the form of this dotted line. So if you pick up any vial from the market, you will see that it will say it can neutralize 0.6 milligrams of cobra per ml of cobra or Russell's viper venom. So if this peak meets this line, it means that it performs as marketed. So as you can see, it does as marketed against the Southeast Indian population, the Andhra Pradesh population, which is the neighboring population of Tamil Nadu, from where the venoms are sourced for the manufacture of commercial antivenoms. This is also the coastal population, so the venoms probably don't differ so much. So the antivenom performs as expected. But whereas against all other populations, the antivenom lacks efficiency. Particularly concerning was the finding against the Rajasthan population, where every single mouse dies. This is also very interesting because this population had really less potent venom, and this again suggests the importance of cardiotoxins. If there are no neutralizing antibodies against them, then obviously it's not going to do much in neutralizing those envenomation symptoms. Surprisingly, you would expect something similar for the pan-Indian populations of Russell's viper as well, but we actually saw that it performs as marketed against the majority of the populations, barring this North Indian population from Punjab. But you must realize that these tests only look at the abilities of antivenoms in neutralizing the fatal symptoms, and they don't really look at the abilities to neutralize morbidity. So I have summarized the results of the major findings of this study, these two papers, as well as one of the previous papers on this map. Here, the red clouds indicate the snakebite incidence as reported by Suravira et al. So, and I have also indicated the neutralizing potencies as these dotted lines, and the proportion of neutralizing antibodies as these colored solutions for the respective species of snakes. As you can see, the antivenom performs poorly against most of the pan-Indian populations of Naja, and particularly fails against both Naja, Russell's viper, as well as the common crate in Punjab. And of course, it completely fails in Rajasthan. So what we suggest is that India needs to actually make regionally effective antivenoms by sourcing venoms of all the medically important snakes by the region. At least as per me, I don't think producing a single product for the entire country is going to work, because there won't be enough antibodies, like neutralizing antibodies against, especially considering the diversity of snakes that we have and the plethora of toxin types they secrete. We have also been sequencing the venom glands of distinct populations, and we already see huge variability in terms of their sequences. So not just the proportion, but the activities are also going to differ significantly. So we propose that we should firstly improve the neutralizing potencies. So the neutralizing potencies of our antivenoms are somewhere here, as I suggested, whereas some of the antivenoms abroad have a neutralizing potency of close to 4 milligrams per ml. Of course, these are monovalent, so they're going to have much more antibodies, but pushing this to somewhere around 2 mg per ml is expected to offer better clinical efficacy. Based on all the studies that are happening in the lab, which hopefully you'll see in the next coming years, we suggest that India needs to make at least 5 distinct cocktails of antivenoms. The amount of neutralizing potencies in each of these Indian antivenoms is really low compared to some of the antivenoms that are manufactured abroad. So that also needs to be improved significantly. Instead of just looking for binding, we should also look at the preclinical efficacies of these antivenoms. And finally, the antivenoms needs to be tested in clinical setting, because that is what will actually tell us whether the antivenoms perform well in humans or not. So with that, I will end my talk here. I would like to thank all the collaborators, all the wonderful students in the lab, all the funding agencies, and the forest departments. Thank you so much for inviting me to give this presentation, and thanks so much for patiently listening.
Thank you, Karthik. We've heard you a couple of times before. Very impressive work. And all of us would agree that you're on the right path, and the studies that you're doing would throw a lot of light on, what really needs to be done, even from the clinical side.
Thank you. Thank you so much.
2 questions, sir.
There are 2 questions for you. Yeah, just read it out.
What is the principal reason for venom variation in the same species within region? Do we find venom variation between juvenile and adult snake of the same species? The question is from Srinivas. Yes.
Yeah, absolutely. So the first reason, like I said, is the ecology and the environment. Venom has been primarily shown to differ based on what the snakes eat. And yeah, there are many studies abroad where people have showed that individuals change their venom profiles over time as they shift diet.
One more question. This is from Jivanjo. Did you estimate the venom yields in different population samples? And in this regard, what is the estimated number of vials for the different antivenoms available in India against Naga Naga?
So we did calculate, but I'm not sure whether there is any direct correlation between the amount of neutralizing antibodies and the number of vials required. So we did calculate it, but we didn't report. And we also calculated the amount of venom that is injected by different populations. Some populations, like the Central Indian population, yield close to, on average, around 400 milligrams of venom in one. I don't know whether they inject all of that into a bite victim, probably not. But at least when you force them to envenomate, eject their venom into that vial, then they do put out close to 400 milligrams of venom in one bite.
Dr. Karthik, I have one question. Do you have any anti-venom for hound-nosed pit viper? That is one of the common snake bites we come across. Any plan for making a monovalent anti-venom for this hound-nosed pit viper?
I would be able to answer that question in a few months down the line. We have been looking at that as well. But yeah, I completely agree that at least in vitro conditions, it doesn't look like it offers any protection. So administering polyvalent antivenom for treating hound-nosed bite, at least in the preclinical setting, does not seem to be a good idea. But yeah, in a few months' time, I'd be able to answer that much more confidently.
Any more questions, sir? Thank you, Dr. Karthik, for this excellent presentation. We learned a lot of new things about how the anti-venom is produced, what are the differences from various areas of India. Thank you once again for participating in this wonderful conference.
Thank you so much.
Do we have Dr. Tarun Sharma on board? You can hear me, sir?
Yeah, so good afternoon all.
Yes, I will briefly introduce you first to the audience of Dr. Sharma. Dr. Tarun Sharma is a senior research scientist in Translation Health Science and Technology Institute, Faridabad. He is going to speak on a very fascinating topic, something that is going to be intriguing for the entire audience. He will be speaking on application of Aptamer technology for the detection of snake envenomation. I'm sure the entire audience is waiting with rapt attention for your lecture, Dr. Sharma. The online stage is all yours. Please carry on.
Okay, so thank you so much. I'm happy to present my work at annual Snakebite conference. Am I audible to all?
Yes, you are. Perfectly.
So I work at Translational Health Science and Technology Institute based in Faridabad. So I lead a lab which is Aptamer Technology and Diagnostic Laboratory. So I will not go into the detail of the problem of snakebite. Karthik has already made my task very easy. So, but if I'll briefly touch upon the problem of snakebite. So this is the Wellcome Trust data. You can see easily that approximately 50 people are bitten by the snake in every 5 minutes, and 50% of them are actually having the case of real snake envenomation, while other 50% are the dry bite. And among these 25 individuals, 4 will be permanently disabled and 1 will die. So currently there is the only treatment available for the snake bite is the administration of the polyspecific venom. And in Indian subcontinent, we have 4 major species that we call the big 4, which is the cobra, cat viper, and the soy scale viper. So in order to administer the polyspecific venom, it is always good if you know the real cause of the snake envenomation, whether it is dry bite or it's a real bite. But unfortunately, in Indian subcontinent, we don't have a approved or validated diagnostic test. So one diagnostic kit available in the market is developed by an Australian company. But since we have a different snake species, same kit cannot work effectively in the subcontinent, and that kit is very expensive. So it is good to have a tool or a reagent that could serve the purpose for the clinical diagnostic, epidemiological, and the forensic investigation. And another problem with the current diagnostic method is that sometimes the morphological similarity can lead to the misdiagnosis. So this is one of the classical study done by the team of Duncan Hospital. So they showed that in the Duncan Hospital, approximately 75% cases of the common wolf snake, which is non-venomous, was misdiagnosed as a krat, which is venomous species due to the morphological similarity. So imagine a situation where a person is bitten by the common wolf snake. If you misdiagnose it as a krat and if you administer the polyspecific venom, it may cause huge allergic reaction. So it is good to have a diagnostic test for various reasons. Number one, for the clinical diagnostic, number two, for epidemiological, and the third, for the forensic investigation as well. So because there was a report from the Andhra Pradesh that Andhra Pradesh government has started a scheme called Apat Bandhu. In that scheme, the family member of a snake bite victim was benefited with the compensation of 2-3 lakh rupees. So there was several false cases of snake envenomation was reported, but unfortunately there was no good diagnostic kit available for the forensic investigation. So a good diagnostic tool can serve multiple purpose. So this is the problem associated with the snake bite. But in addition to it, there is another problem in the area of diagnostic, which is associated with the currently available diagnostic modalities. So if you see here that current diagnostic market is heavily dependent on antibodies. It could be the poly or monoclonal antibody. So because the antibody is raised in the animal, so they have huge batch to batch variation, because you cannot control the physiological variation of one animal and the other. And the problem is that if you are trying to generate monoclonal antibody, you have to maintain the clone, and being a protein, you have to store it at the room temperature. So there is a stability issue, and the cost is another problem. So in recent year, the Aptamer technology has emerged as a chemical rival of antibody, which can address these issues, because in order to generate Aptamer, you don't need an animal. So what exactly the aptamers are? All of you are aware with the DNA or the RNA. So the classical function of the DNA or RNA is that it can pass genetic information from one generation to the next. But in addition to this, when a structured DNA or RNA molecule is synthesized through a process called cell systemic evolution of ligand through exponential enrichment. So this structured DNA molecule can bind to its target with a high affinity and specificity. And this process of aptamer development is similar to the in vitro evolution that I'll show you in next couple of slides. And advantage is that you can generate aptamer against several small molecule. You can generate against the toxin which are non-immunogenic, because another problem with the currently available valent venom is that there are antibody, the majority of the antibody generated in the hearts against the molecularly complex venom component, not against the small molecular weight venom component that are lethal. So aptamer can be generated against the low molecular weight toxins, small molecules, protein, receptor, and even against the whole cell. And being a synthetic molecule, you can get it synthesized easily, so there is no batch to batch variation, and it can be used as a diagnostic tool. So these are some example of the diagnostic tool. And there is one aptamer based drug is already approved by the US FDA, and currently it is in the market, which is a Macugen. So now I'll show you the data that we have generated from our lab. So this is unpublished data. So you know that the krat is one of the big four snake. So it has, it belongs to the family of elapid. So currently there is no good test available for the krat venom. So what we did, instead of using the purified venom component, we have used the crude venom for the aptamer selection. So first, we have a huge aptamer library which has millions of sequence. So if I give you a metaphor, imagine you have a lock and you have a bunch of keys. So from those bunch of keys, you need to fish out one or two keys that can open your lock. So similarly, we have this library, which has millions of aptamer sequence. We have first incubated this library with the venom of Naja, WRSLE, and Akis, so that the cross-reacting species can be ruled out. And those which is not cross-reacting, it was incubated with the venom of CRET. And these species was then enriched, amplified, and then this process is repeated again and again until we get the high affinity binder. So you can see here, after 8 round of aptamer selection, we got very good binders. And this is the starting point, the library. So in comparison to the library, you can see the aptamer when after 8 round of the aptamer selection, the binders population increased significantly. And these population were then cloned and sequenced, and based on the sequencing data, we have picked the top 10 aptamer candidate. And you can see here all 10 aptamer showed binding with the CRET venom, all albeit with the different degree. So then we evaluated the cross reactivity of all 10 aptamers against the venom of big four. So some aptamers were showing cross reactivity like this, but other aptamers showed a specific response for the venom of CRET. Then we picked the 6 best performer out of these 10 aptamer and evaluated their cross reactivity against the various snake venom like the CRET, Naja, Kotia, Naza oxiana, WRSLE, Bangaras fasciatus, Niger, Achis carinatus, and also against the scorpion scorpion venom. So you can see here that some aptamer like B6 and B8, they are showing very specific response, and it is not showing cross reactivity with the cobra or the scorpion or the Achis snake venom. So then we predicted the structure of these two aptamer, B6 and B8. So this B6 aptamer is showing actually 2 hairpin-like structure, by B8 aptamer is showing just 1 hairpin-like structure. So what we did to establish the structure activity relationship, we actually truncated this aptamer. So what this we have, and then we tested it individually. So you can see that when these two hairpin structure assessed for their binding independently, it was not showing any binding, while the parent aptamer having both these stem loop like or the hairpin like structure, it was showing very high binding. So possibly that these two loop like structure are actually contributed for the venom binding. Similarly, here the parent aptamer worked better than the truncated, and both when we did CD, both aptamer showed B-type DNA structure. Then we determine its KD or the affinity constant. So as you can see here, that B8 aptamer showed KD of 48 nanomolar, while B6 20 nanomolar. And then we did their limit of detection. So both these aptamer can detect as low as 2 nanogram of crude venom. Then what we did, we evaluated the ability of aptamer to detect the presence of venom in the serum background. So you can see here, even in the serum background, these aptamer can detect the presence of venom, and they can detect as low as 2 nanogram of venom. So in the last talk, Karthik had showed a very interesting data on the venom variability. So in order to test whether our aptamer can recognize the venom of different geographically different population of the same snake species, we took venom sample from the 3 different parts, the West Bengal, UP, and the Tamil Nadu. So you can see here our aptamer, both the B6 and B8 aptamer, was able to detect the venom of CRET from the different geographical location, albeit with the different degree. So it is showing the aptamer binding is higher for the venom of central India, I mean the UP, in comparison to the southern part and the eastern part. So the possible reason could be because there is some different I mean, in the next slide, I will show you that our aptamer actually bind to the beta bungarotoxin. So we have identified the target of the aptamer as well. So possibly the amount of beta bungarotoxin is higher in the central India population in comparison to the eastern and southern India. So so finally, we have identified the target of aptamer as well. So through the mass spectrometry, so what we did, we first run the gel SGS page for the venom, and we transfer it on the membrane, and we probed it with our aptamer. So it showed that aptamer was able to pick a single protein. So when we identified this protein from the gel, and so based on the mass spectrometry, so this protein was identified as a beta bungarotoxin. So this much data we have generated. So now our aim is to translate this research lead into a commercially viable diagnostic product. So we are aiming to develop a rapid diagnostic test, possibly the lateral flow or any other strip-based test or the electrochemical sensor. So this is my team member, Anjali, who has actually contributed to this work. And I would like to thank my collaborator, Dr. Khandelkar, Dr. Amit from IIT Indore, and Dr. Anita Malhotra from the Bangalore University. And I would like to thank DBT and BIREC and THSTI also for the funding. Thank you. Thank you for your attention.
Thank you. Thanks, Tarun. Great work. And have you finished with it? Is the project over, your DBT project?
So it will be over in February.
February. Okay.
Actually, through this conference, I'm also looking for the clinical collaborator so that we can validate the performance of our aptamer in the clinical sample, maybe retrospective or in retrospective way, if some of them have the archived specimen with them.
Okay. And what about this? Have you done the animal studies? I mean, in small animals, sensitivity, specificity?
So we are actually not aiming for the therapeutic intervention. It is solely diagnostic work. So that is why we have not tested in the animal.
Okay. But I think it would be prudent to do that before we go into the human studies, Tarun.
One small study we did, I have not presented that data. We have got some samples from CMC Vellore, some CSF specimen of the Snakebite, and we found that our aptamer was able to detect the presence of venom in the CSF specimen.
Great. And you're happy with the sensitivities also?
This sensitivity could be improved further if we change the diagnostic platform. For example, instead of this colorimetric platform, if we use the electrochemical sensing platform, then sensitivity could further be enhanced.
Great work, Tarun. And there are a whole lot of seniors on this Zoom meet, and you're one of the younger scientists that we are all looking up to take this course forward. And keep up the good work, Tarun.
Thank you so much.
I'll just check whether there are any questions on the chat box, Tarun, for you. Just a second.
Sure.
Dr. Sharma, the first question is, do you think that the aptamers could be used to generate an antivenom, either aptamer only antidote or to complement antibody-based antivenoms?
So I think yes, if we can carefully design aptamer against the specific components of venom, like in Karthik's talks, he has mentioned about the importance of the three-finger toxin. So if we can develop aptamer against the three-finger toxin, which not only bind but neutralize also, then we can use the combination of aptamer and antibody. And if aptamer itself is very potent, it can neutralize the effect of venom. So certainly there is a hope that it could work. And because in the several other diseases where neutralization is necessary, the aptamer has proven its role as a therapeutic agent. One example is this macugen, which is used already in the market for the wet age-related macular degeneration. And there is another aptamer-based drug is the antithrombin, based on the antithrombin aptamer, which is in the phase 3 clinical trial. And there are many other aptamer-based drugs which are in clinical trial.
Thank you, Dr. Sharma. That question was from Joanjo, and you have one more question from Maharshi Pandya. Sir, out of pool of proteins in crude venom, how do we ensure that the protein against which the aptamer binds is immunogenic or non-immunogenic?
So see, in this particular case, we have used the crude venom as a target. So beauty of this process is that even if you don't know the specific biomarker, you can get the specific aptamer by using a strategy of selection and counter selection. Like in this case, we did the counter selection with the three venom, which is the cobra, russell viper, and the soy scale viper, and selection with the crate venom. That so initially we did not know the target, but once we have the specific aptamer, we have identified its target. So initially, you don't know whether it is immunogenic or non-immunogenic. But if you are doing, I mean, the experiment in this way, then certainly you don't have any clue. But if you are dealing with a protein and you know each information about that protein, like its molecular weight, pH, and everything, then you can say that it's a non-immunogenic or immunogenic.
I'll take one more question that is from Karthik Sunagar. You spoke about commercial kits. Don't we need aptamers for the other three species as well?
So, Karthik, yes, I agree. So, we are developing aptamers against the other three species also. So, this is just one data that I have presented. So, we have also, trying to develop aptamer against the three-finger toxin in collaboration with Robin Dole from Tejpur.
Great work, Tarun. So continue to keep up the good work.
Thank you so much, sir.
Okay, so we move on to the next topic. That's the next lecture would be delivered by Surajit Giri, who's a consultant anesthesiologist and a critical care and palliative care physician from the Demo Community Health Center at Shivsagar district in Assam. So he would be putting, this is a topic that's never been covered over the past 12 years. That is, he will give us an understanding of how he treated over 100 patients of green pit vipers. Go ahead, Surajit. All the very best.
Yeah, yes, sir. Thank you, and good afternoon to all. And the screen is not set.
We'll share from Hello?
It is not sharing. You can share from your plus.
Yeah, sure.
Yeah, you said okay.
Yeah, you can start.
Go ahead, Surajit.
Yeah. So thank you, Amrita Institute and Dr. Menon, for giving us the opportunity to submit our views regarding our pit vipers, which is available in Assam and NE. Next slide, please. Next slide. Hello. Yeah. So no. Previous one. The previous one. Yeah. I declare and thanks the cost that I have taken the consent from all patients that I have taken the photograph and they have given the consent for the publication. And I must thank our rescuer, that is Prasanna, Manasjyoti, Tejaswita, our doctor, Dr. Sanjeev Burra, Mrinmoy, Ariful Islam, Khogen Dole, Chandan Borbora, the Dulesar Gwara, Partha, the member. We have our WhatsApp group with the public and all members of the WhatsApp group, all family members of the victims, all the public and of the demo and the Shivsagar, and definitely some NGOs. And because of our collective effort, we are going to submit this report to all of you. Next slide. And I am from this place. This is the small place, Shivsagar, which is around 400 kilometers east of Guwahati. And we have our northeast state like Meghalaya and Nagaland and Arunachal Pradesh. And they have also given some input about these cases. Next slide. So we are talking about Trimerosaurus species, which is around length of around 1.05 meter. And primarily they are arboreal species and the head are triangular and their heat sensitive pits are there. And typically they are green in color, but some species are yellow, black, orange, red, and even the gold markings are there. Next slide. Now, whenever one want to practice a snake bite area and wants to work on the snake bite area, especially in India, he have to fight against the infrastructure. He have to fight for the availability of the ASV. He have to fight for the manpower. He have to fight for the machine. He have to fight for the medicines, means the essential equipments and the medicines. They all have to fight it. Now, this three is possible to fight, but the fight against the false beliefs, fight against the superstition of the society, of the people around us is very challenging. Next slide. Thinking that this is the main issue, means community awareness is the main issue, because the people, once there's a snake bite, they goes to the faith healers, they goes to the babas, they goes to the tantric, and if they doesn't come to us, we do not know what is happening, and we do not know what is the venom dynamics. We do not know what is going to happen to the patient. We do not know what type of snake bite is going on, what type the snake venom, what does he does to the patient. We do not know at all, because that time when we have started in 2010, there is a very few hospital notification, because they do not have any faith on us, faith on the medical treatment, and we as an doctor fraternity also, we are not bothered about that. Next slide. So think that community is the main issue. If we ever the community, if they come to us, then only we can able to understand this venom dynamics. And we have started lot of community awareness program in that time with a lot with the NGOs and all. And we have taken the Facebook this help also. We have this social media with the extensive awareness program we have started, and people are gradually coming to our hospital. Next slide. Next slide, please. Yeah. So at that time, no, previous one. Hello. Yeah. At that time, our understanding and approach to the viper bite was, if there is a progressive swelling, if there is a pain, if there is a coagulopathy, give anti-snake venom injection. That we are taught. And there are days of coagulopathy. And because this patient, after treating, suppose after 3 to 4 days, there is no pain, no swelling, and patient doesn't want to stay in the hospital, and they discharge against the medical advice, and we lost the tracking of this group of patients. And again, we are not bothered about these patients, ladies and gentlemen. Next slide. But this is a breakthrough case to understand this viper bite in our area. He is Navajyoti Gogoi, bitten by pit viper. He has a pain and swelling. There's no blood clot till infinite time. So we have given 10 vials of ASV in our hospital. INR was not measured by the machine. And as we do not have any blood products, we have shifted the patient to medical college, which is around 100 kilometers from our place. There again, 10 vials of ASV was injected and FFP was injected, that is three vials. Still, there is no blood clot, but he had no symptoms of bleeding at all. But the blood clot was seen at 10 days. Now, what has happened? We're tracking to this patient. We have tracked those treating doctors, and we are in the constantly touch. So what is happening? Because you see, we have given the anti-venom injection, we have given the FFP, but still the blood is not clotable. And as at the 4 to 5 days, swelling decreases, pain decreases. Navajyoti Gogoi, he went to whom against the medical advisors on 4th day. And we call him, then ask him to come, because already his blood is not coagulable. His iron is still high, but he's in the risk. He's in whom itself. So I call him and ask him to come in at 7 days, but he came at 10 days, and 10 days you can see the blood there's a good blood clot was seen. Next slide. And in 2016, another few cases we found. Again, the protocol was same. 10 vials was injected here, shifted to medical college, 10 vials in the medical college itself, and FFP was given in the medical college. But the question is, there is no reverse in coagulopathy. Then we thought that we are missing something in pit viper bites. Next slide. Now the protocol is that is from 2018 to 20, because you see, we have injected the FFP, we have injected the ASB, still patient has no reverse in coagulopathy, means blood is not clottable up to 10 days. So we stopped giving the FFP, we stopped giving the this anti-snake venom in pit viper bite. Even if there is a progressive swelling, even if there is an intense pain, even if there are coagulopathy, we are not injecting ASB to our patient. Tramadol was injected for pain, trypsin and chymotrypsin for swelling, and absolute observation and absolute bed rest. Next slide. So the snakes are identified by the color of the snake. The most of the time, these snakes are very lazy snake. They took the mobile photograph, and thanks to the smartphone, and sometimes they caught the snake to us, and also the posture of the snake, like S-shaped posture after bite. And the diagnostic was the no blood clotting till infinite time, 20-minute whole blood clot test. Next slide. So this is our in our hospital, and we have our SR showing the venomous snakes available in our Assam, and they says, oh, this is the snake, this snake bitten me. So they identified the pit vipers like this also. Next slide. So sometimes they caught the snake like this, and then we identified, oh, it was a pit viper. Next slide. Next. Hello. Yeah, and we have handed over almost around 10 pit vipers to the forest department. And this is the mobile photo that patients take to us. They took the photograph of the pit vipers and came to us. And this one is the pit vipers who entered in the bed and bitten the patient. So all took the photos and they come to us, but we treated it conservatively. Next slide. So this is our data, 100 numbers of the patient. Inclusion criteria was all bites by the pit viper, 20-minute whole blood clot test, there is no blood clotting. And it was a retrospective chart review from 2 hospitals, that is one government community health center, that is Demo Community Health Center, and another was the private hospital, Pragati Hospital, and in the year of 2018 to 2020. Next slide. So the distribution of cases, in 82 numbers of the cases, I was directly involved, and in 18 number of the cases, the reports came from outside of Shivsagar. Outside, there is 2 from Nagaland, 1 for Meghalaya, 2 for Arunachal, and other parts of the Assam, there is 13 cases was reported. And in these cases, this outside my places, Shivsagar, I told them that do not inject ASB, do not go for FFP, etc. You just observe in 6 days or 10 days, blood will be clotted. And everybody, this all 100 numbers of the patient is surviving till now. Next slide. So 38% was upper limb bite and 62% was lower limb bite. Next please. So when the patient came, 91% has severe pain. VAS score 10 by 10 means we always measure the pain in the 0 means no pain and 10 means worst imaginable pain. And it is a 91% of the patient having the worst imaginable pain and 9% of having the mild pain. VAS score of around 4 to 6 out of 10. Next slide. Swelling, 76 numbers of the patient has involving the 2 joints and 24 having only local swelling. Next slide. We monitor the swelling. Swelling monitoring is important. Otherwise, sometimes there may be a compartment syndrome, and sometimes you have to accentuate the limb also. So we measure the temperature, the progression of the swelling, distal peripheral pulses in all fingers, tenderness, as well as the spontaneous PTK. If there is not, we always monitor the swelling. Next. These are the swelling you can notice. These are few of the cases. Next. Next, previous one. And you see, in 62% of the patient, there is no blood clotting on admission. So I have already told, because of the extensive public awareness program, people are coming in a very few hours of time. If there is a snake bite, they come to our hospitals. So on admission, 62% having no blood clot status, but 38% of patient, there was clot on admission, but after 12 hours, there is no blood clot at all. Next slide. But see, we have not injected FAP, we have not injected any ASB. Blood clot was seen in 21% in 6 days and 79% in 10 days. And probably those, if the venom was injected less, the blood clots in 6 days, and if the venom is injected more, blood clots in 10 days. But it is a spontaneous effort. We are not inducing any coagulation. We are not injecting any blood product. We are not injecting any FFPs. Next slide. So what we have observed, swelling subsides by 6 days, automatically subsides with the help of trypsin and chymotrypsin. Fatal spontaneous bleeding, we have not noted any. Hemodynamic changes, nil. Kidney injury, nil. We have monitored by serum creatinine level. Next slide. The warning we have given to the patient is absolute bed rest till the blood clots, only essential activities like toileting, etc. Significance of the blood not clotting explained, close monitoring of everything is required. And we tell them, do not do any type of injuries. Means you have to prevent the injuries. You have to be in the complete bed rest. You are in the risk. Anything may happen to you, but we are ready to treat you. Don't worry. Next. So our treatment protocol is crab bandage, limb elevation, trypsin, chymotrypsin, tramadol for pain. And if there is a bed wound, sometimes the people, you inflict with a blade in the bitten area, then we give only the antibiotics. 20-minute whole blood clot test we do in the 6th day and on the 10th day, and we redo that 20-minute whole blood clot test on 20th day. Now when this patient comes, we directly say, see, this is the pit piper, the bitten you, do not worry, swelling will subside on 6 days if the venom is given less to you, and if the venom is given more, it will subside by 10 days, and we are there to help you in every moment. So this, if in the course of the disease, we tell them, and they are becomes very much confident on us that yes, this is happening. What doctor has told us, everything is happening like this, and this is happening in all 100 numbers of the cases. Next slide. So we have abandoned these measures. Previously, we had done in 40 cases, we have done all coagulation profile of the patient. Every alternate day PT, INR, APTT was done. Every day 20-minute whole blood clot test was done. Now, if you every day keep on pricking this group of patients, there is a oozing of the blood. And one patient, we have to press this oozing area, the injection area, for up to 45 minutes. And another patient, we have a hematoma was developed in the antecubital area. So as we know that blood clots on whether in the 6 days or the 10 days, we abandon these whole procedures. Next slide. So in 2020, our protocol is only one test, that is 20-minute whole blood. Previous slide. Hello. Only the test is the 20-minute whole blood clot test. It will not cost anything to the patient. Number one. Number two, quality time with the patient and the family. You have to make them convinced that this is the things happening and we are there to treat you. Explaining everything means he is at risk. Significance of the blood clotting, you have to inform, because they doesn't know what is the significance of the non-clotting of the blood, and complete tracking of the patient is utmost necessary. Next slide. These are the few patients who were survived without any ASB, without any FFPs or blood product. Next slide. This is the man you see. He was admitted in the hospital for 10 days. We have done 6 days blood clotting. It was not clotted. And at 10 days, we have done it was seen. It is a good clotting was there. He was very much happy now. Next slide. So my submission, next slide. My submission is that Assam and any pit vipers, coagulation may happen up to 10 days. We do not need any FFP. We do not need any ASBs. We need more studies of its venom and its own antivenom, means monovalence. Because you see, we are putting the patient for 10 days. It is increasing the hospital stay of the patient. So if we get such type of antivenom which works and reverses the coagulopathy, that is good enough. But the prevailing what is available antivenom does not reverses the coagulopathy, nor it reverses the other thing. So I should thank our patient, families, and the societies, because they, after biting, they came to us, and as the patient's turnover increased to us, ultimately we could know that yes, this is the scenario, this has happened to us, and this understanding is from the patient, not from the book or not from the research, ladies and gentlemen. Thank you very much.
Thank you, Surajit.
Yeah.
There are a few questions on the chat box. Just try taking them, Surajit.
Yeah, sir.
Doctor, from Zangli to everyone. Sir, if a venomous snake bite itself, will the snake survive? And if so, how will the toxic get neutralized?
Means regarding the pit vipers, or?
If a venomous snake bite itself, will the snake survive? And if so, how will the toxic get neutralized?
I don't know, because I do not have any research, but what I have submitted, this is all my patient findings.
There are places where low dose ASV were given to bite victims. Probably all these could be PV. From Dr. Rajiv.
I did not got the point, sir.
This is, there were certain cases of hematotoxic bite in which low dose of anti-snake venom was given. So
sir.
Rajiv's belief is they probably could be pit viper.
Probably, sir. Probably means this is the pit viper actually.
Okay, next.
From Dr. George Paul, is there a follow-up later? Did any of them develop acute or chronic kidney disease, as seen in other vipers? Many long has severe CKD.
No, sir. We are completely tracking this patient. All patient has phone numbers, address, everything with us, and we many a time we call them if there is any problems, everything. Nothing is happening to this our patient. All 100 patients.
I have a question, Surajit.
Yes, sir.
What prompts you to give chymotrypsin and trypsin?
Because, sir, there is a lot of swelling, almost covering 2 joints. That to decrease the swelling only we use the trypsin and chymotrypsin.
And you think it has benefited?
I think, sir. I think so.
Yeah. The other thing is, if you have the details of 20-25 patients of serial APTT-PT, it is well worth publishing. Correlating
Yes, sir.
with clinical symptoms.
Yeah. Already, I have already this one, and then already I am gathering this all information. Probably we are going to publish soon, sir.
Very good.
We have a question from Siju. How long was the 100 patient followed up?
How long? 100?
Yeah.
It was followed up for 1 month by phone calling, WhatsApp, messaging, and after 1 month, if they have any problem, then we ask them to call us.
One from Joseph, sir.
Dr. Joseph has a question.
If Russell is viper, how did you differentiate Russell viper bite from green pit viper?
Yeah. The thing is that, sir, in Assam we do not have any Russell viper. That is the thing, because in Assam only we have pit vipers. We do not have any Russell viper, or we do not have any soy scale viper, and that's making us easier. Because any prolonged coagulopathy we presume to be a pit viper bite, sir.
I have
in
one
Assam.
question, Dr. Surajit.
Yes, sir.
You mentioned in your approach to these patients the use of a crepe bandage.
Yes, sir.
Crepe bandage, you are talking in terms of something like a Sutherland wrap. You are winding that bandage around the entire limb. Is that what you are advocating?
Actually, one thing, sir, this is a psychological benefit only. Many a time the patient says, "Sir, patient, you still told us that it is a venomous bite, it is a dangerous bite, and you are not injecting any anti-venom, and the limb is swelling like this, huge swelling." So what I did, I took a crepe bandage and applied it there on the limb, the bitten limb, and they actually they do not see that the swelling limb. It is only the psychological benefit I've given it.
I
There
mean,
is a-
understand this because in viper bites, local manifestations are quite severe, isn't it? Including pit vipers. So, after of crepe bandage, would it be detrimental or not? I'm having a bit of a doubt.
No, sir, it is not given tightly. It is just wrapping only, sir.
It's covering it.
Yeah,
Okay.
just covering only. Just covering it. So
Okay.
that they doesn't see that swelling limb, because otherwise they keep on asking. So you have not injected ASBS. You said it is a venomous snake, and still you are not doing anything. Especially in first 40 cases, I got this type of answer, and that is why we apply this crepe bandage, and they doesn't see the swelling room. That is only the psychological benefit.
Thank you.
Thank you, sir.
Surajit. So before we go on to the next speaker, it's about 1 hour and 20 minutes that we've all been sitting. All of you all would agree that being sedentary doesn't actually help. So there's a 2-minute stretch out exercise. So why don't we all just stretch our aching muscles a little? So can we have the video?
Down to your knee. Often gets tight if you're doing dynamic exercises, running. Plyometrics. We're going to step behind.
Yeah.
With our right leg.
If necessary, you could join us.
Arm, we're going to reach up and over, driving that right hip to our right side. Feel that stretch all down our side, our obliques, and right in through that iliotibial band. Keeping good posture while you do so. Your back moving forward, but only bending over to the side. And really focus on taking that right hip and
popping it out.
Popping it out. That's it. You got it. Again, breathing and holding. And let's do this one for 5, 4, 3, 2, 1, 0. Relax. And let's move right into that opposite side. Try not to fall over. Okay, let's take our left foot, step behind. And the bigger of a step you take, the more of a stretch you're going to feel. Again, you decide what's right and appropriate for you.
This isn't something I stretch out often.
Not often enough.
Super.
Feeling it.
Tight.
Super tight. You can tell this.
Next session. 1 minute तक मत No.
Can we start?
I don't think the exercise went down very well with anyone. Dr. Joseph has not budged from his seat. So we'll move on to the next session.
Next topic is snakebite challenges in Northeast. The speaker is Vishal Chandra. He's the executive member and research head, Society for Nature Conservation, Research and Community Engagement. There is concern. Co-founder, co-director, captive and field herpetology. The topic is snakebite challenges in the Northeast. Welcome, sir, for this topic presentation.
Oh, thank you very much for having me. Am I audible?
Yes,
Yeah,
yes,
yes.
yes, sir.
Go ahead.
Thank you. I can't see my screen.
1 second.
Can you?
Not yet.
1 second.
Yes. Okay, good afternoon, everyone. Thank you for having me here. So I'll just, so our work is almost in line with Dr. Karthik Sunagar from the Evolutionary Venomics Lab at IISc. We do have a few other components that we thought would be benefit when we are working on snakebite. So I would be talking about that, and I'll be highlighting a few of the major challenges that we face when we try and talk or discuss snakebite in the Northeast. Can I do my own slide changes? Yeah. Okay, next. Yeah, this is the team we have been working with. It comprises of Bangor University from the UK, and in India we have Tejpur University, CCMB, Mizoram University, forest departments of various states in the Northeast and the North. Hello.
Just one second, Vishal.
Yeah.
Can you give him share screen? Can you go ahead, Vishal?
Yeah, thank you. So this is our team that has been working on the snakebite front in the north and the northeast of our country. Next.
Next slide.
So this has been talked about over and over again. Snakebite has been brought back to the NTD by the WHO, and the sad part that I feel about snakebite in India is this. Next, please. Is that there is that one study and that one data generated, a decade ago, is the only source of epidemiological information we have on snakebite in the country. So much is being talked about, so much is being discussed about and presented about, but the epidemiological front of snakebite in the country still remains evasive. There is no doubt that this is a major public health problem. Next. Next. Yeah, so this is another trend that I have been personally observing for quite some time during different snakebite conferences, that we always try to tag snakebite to some sort of occupational hazard. We have sort of failed to realize that snakebite does not necessarily mean an occupational hazard. It is basically a rural hazard. If you look at the numbers of snakebite, if you look at the few publications available from India, you'll see that people getting bitten in farmlands compared to people getting bitten inside the house, outside the house, while sleeping, while walking in the village vicinity, while walking on the road, is far more than people get get bitten during farming activities or any kind of harvesting activities. So next, please. So I think the trend of neglecting different aspects of snakebite is because the victims of snakebites are from a rural background. They tend to be poor. They are, a lot of them are children, and they lack political voice. And that's one of the reasons why snakebite is neglected wholesomely. And that's one of the reasons why we also fail to look at snakebite in a very holistic manner. Next, please. So you all are very familiar of this map. Next. So these are the areas from where the researchers didn't find any data. I'll be focusing on Northeast. Next, please. Yeah, so when we started looking at snakebite in the country, we categorized short-term fixes, which are basically strategies and components and tools we already have on hand, which can be bettered, which can be modified, which can be worked on. And then there are long-term strategies which will happen to be the game changers in the future, where public health and epidemiology and clinical management come into the picture. Next, please. Next, please. Next, please. Everything boils down to antivenoms. Now, with all the work that has been happening, with the fantastic work Karthik Sunagar has been doing at his lab, and many other researchers have been engaged in venom research, most of our end result revolves around whether a certain antivenom or the present Indian polyvalent antivenom is effective against a certain population of a certain species of venomous snake in a certain biogeography of India. So I'll be talking around this issue mostly. Next, please. We all know about this, that it's been the polyvalent antivenom in India is being manufactured and designed against 4 major venomous snakes known as the Big Four, which is a big problem. But nobody actually considers whether these snakes are spread across all other geographies in India, whether the snakes are the same molecularly, whether the venoms are the same, or they differ. Next, please. Yeah, so the challenges for the Northeast were there were very limited scientific documentation of snakes there, almost unavailable epidemiological data from the region. We had no idea which are the medically significant venomous snakes there. There are a lot of venomous snakes there, but which are medically significant, we still don't know a lot of it. Venoms were not characterized until recently. Karthik has analyzed a lot of Northeast venoms. We have also been doing some analysis of our own. And there are very limited, published case studies, but thanks to Dr. Surajit, who is doing a fantastic work on pit viper and venomation cases. And once he publishes that data, it will be a fantastic tool to have to address other aspects of snakebite in the Northeast. Next. Yeah, so I'll be talking about Mizoram, where we had been working since 2016. And Mizoram is a wet tropical evergreen forest covered state. 98% of the state is mountainous. I would like to stress one point here when I say I would like to speak about Mizoram is our sampling strategy. So one thing that Karthik has already mentioned in his talk is about the evolution of a species and relating the venom characters of that species to how it evolved and how its prey item co-evolved with it. So a lot of information remains within the natural history of a certain species that we are working on. So when we are dealing with snakebite, when we are trying to decipher a lot of mysteries revolving around snakebite in India, and we are sampling snakes, we are analyzing venoms, we are characterizing venoms, we are doing antivenomics work, we tend to neglect or avoid the natural history of that species. So that needs to be roped in when we are analyzing venoms and trying to translate that in terms of human health. So next, please. So we have sampled these few districts in Mizoram. We failed to sample southern Mizoram because of extreme conditions of roads and also terrorist activities near the Myanmar border and Bangladesh border. Because of safety issues, we couldn't go there, but we are at the moment talking with the extreme groups in those regions so that they allow us to come there and give us safe passage to come and sample snakes. Now, the problem with terrorism in the Northeast is that if you are out about with your headlamps on looking for venomous snakes to sample, you either get shot by the defensive forces of India or you get shot by the terrorists. So both way you die. So we are trying to make sure that we don't die in the field by sampling venomous snakes. So we have left that chapter for later analysis. Next, please. Yeah, so from 2016 to 2018, what we have done in this state is we have done some systematic documentation of venomous snakes. We have identified snakes at the molecular level. We have looked at how closely species are related and how far the species are not related with each other. And one must understand that when we talk about Northeast, we talk about not just a political boundary, we talk about biogeography. And technically, Northeast falls within the Southeast Asian clade. So most of the snakes in Northeast are much more closely related to their Southeast Asian brothers and sisters, other than mainland India, other than the peninsular or the northern or the southern India. So what we try to do is we try to collect as much specimens and as widely as possible, because that's another problem that happens when you sample venomous snakes for studies. We tend to follow the IRULA cooperative model and try and stick to one district, and according to logistical availabilities, according to easiness of access and all that, we tend to end up collecting samples from just one district of a given geography, and then present it or evaluate it as a representative of the entire state, which can be dangerous in terms of translating it as a state specific finding. So that's one important area that we always try to cover, is we try and sample as widely as possible in a given geography. Next, please. These are some of the specimens we sampled from Mizoram. Next, please. Yeah, so our sampling time revolves around monsoons, and monsoons in the Eastern Himalayas are not fun, because you get stuck due to landslides, and you get stuck for days, sometimes weeks. And with limited funding on expeditions for sampling, because as we have been seeing the trend, a lot of funding goes into next generation antivenom design and therapeutics, we end up working with very limited resources for field work. And we do face a lot of hardship when we are sampling venomous snakes in these remote regions of the Northeast Indian territories. Next, please. Yeah, so these are the medically significant venomous species of Mizoram. So these are the species that are known to bite people. Yeah, these are some of the species that are known to have killed people. For instance, there are a lot of black red bite deaths in Mizoram. There are known and reported deaths from spot-tailed pit viper bites. So I would like to stress one more thing. The species that we have been seeing in Dr. Surajit Giri's talk is the recently described Salazar pit viper, or the Trimeroceros salazar. So that pit viper venom may not be as toxic as some of its closely or far related species like the Pope's pit viper or the spot-tailed pit viper, or even the mountain pit viper. I should also make it a point that all the Protobothrops species of pit vipers found in the Northeast are very large, with very big venom glands, with very toxic venoms. And we have come across patients in Sikkim where they have been bitten by Himalayan pit viper, which grows. The females of that species grow up to 7 and 8 feet in length, and the males can grow up to 5 feet in length, are capable of delivering huge quantities of venom. And one of the forest department range officers in Sikkim got bitten by one of them, and he suffered a renal failure, and he had to go get one of his kidneys transplanted. So these are life-threatening situations, and a lot of pit vipers in the Northeast do pack a punch. Apart from pit vipers, there are cobras. One is the monocle cobra, one is the king cobra. The king cobra technically doesn't fall into the Naya genus, but it does have potentially lethal venom. We have not heard about fatal king cobra bite in the Northeast till now, but we have cases documented where monocle cobra bites have caused fatalities. Next, please. Yeah, so along with venomic studies, it's very, very important that you do molecular studies, because that gives you the basic platform to understand why there is species, why there is venom variation within a species and between a species. Because when you do the phylogeography, when you do the phylogenetic analysis, you look at the branches, you look at the clades that tell you why the species is having a different venom composition than the closely related cousin or the parent species. So phylogenetics is very, very important to rope in when you are dealing with venomic studies across India. Next, please. Here also it's the same. The earlier slide was of elapids from the Northeast. This is the viperid. This is the vipers of the Northeast. They fall into the subfamily of Crotalinae. All are pit vipers. There are rarely any true vipers in the Northeast, but Manipur has recently reported a small population of Rhesus viper in the Loktak Valley, which we believe is either Daboia siamensis or something else. So that species is yet to be analyzed and scrutinized. Next, please. Yeah, so coming on to venoms, what we did was we imported the green pit viper venom from the Thai Red Cross Society, and we tested it against some of the Northeast Indian Trimeresurus species. We tested it against the Medoensis, Popiorum, and Erythrurus. So you can see we have also used premium serums antivenom to look at the efficacy or their potential to identify protein bands. So you can very clearly see that the green pit viper venom from Thailand, identifies almost all the major protein bands in the Erythrurus venom, because the Erythrurus is the most closely related species to the green pit viper, for which the antivenom has been designed by the Thai Red Cross Society. So T. albolabris, for which the green pit viper venom has been designed by Thai Red Cross Society, is very, very closely related to T. erythrurus, then T. medoensis, and T. popiorum. So these sorts of studies do give us an idea that phylogenetic studies and understanding species relations is very, very important. Next. Yeah, so this is a reverse phase HPLC of Nycalthia venoms from two regions. One is Mizoram and one is West Bengal, and we have compared that with the Naya venom of the Irula cooperative in Tamil Nadu. So you can easily see the differences in the peaks. All these peaks are like fingerprints, which may contain one or multiple toxins. So we didn't have the option or the collaboration for mass spec studies, but recently we have got a new collaboration where we have subjected all these venoms for mass spectrometry studies, where we will be able to identify all the toxins and we will be able to quantify them. Next, please. So this is a immunoaffinity chromatography based antivenomics analysis of Indian polyvalent antivenom. So we have used against Nycalthia venoms. So we have used a Nycalthia venom from two regions. One is West Bengal and one is Mizoram, and we have used 4 different antivenoms produced in India. And all the chromatography runs suggest that a lot of neurotoxins and phospholipase toxins are not bound by the present antivenoms. So that means that we definitely need a specific antivenom or region-specific antivenoms for the Northeast. Next, please. So this is an analysis of the green pit vipers. So you can see on the top figure that the red boxes actually denote the toxins that are not identical, and the purple boxes denote that toxins that are identical in all these pit viper venoms. One interesting thing is that when we speak about coagulopathy followed by viperate snake bite or a pit viper bite, we do not have the data. We do not have the information as collected by Dr. Surajit Giri from Assam on all the pit viper bites across India. We just do not have the data. So I think it will be a mistake to suggest that pit viper venoms in general are not dangerous and that the coagulopathy will get corrected on the 6th or the 10th day. It may vary from species to species. If you look at the bottommost column, you can see that there are lots of pit viper venoms there of T. medoensis, T. erythrurus, T. popiorum, as well as T. saturnalis, which shows a very strong procoagulant actions. Obviously at different doses, but they do produce pretty strong coagulant activities in the victim's blood. Next, please. Apart from our venomics and antivenomics work and proper scientific sampling of venomous snakes in these areas, we tend to spend a lot of time, energy, and funds on education and awareness and outreach, which is extremely important, as Dr. Surajit Giri has already mentioned. Next, please. We also try and train the forest departments in that area so that they can take care of their own activities like removing snakes, because There has been a trend in India that every second kid in the block wants to become a snake wrangler because Facebook and Instagram and all the social media sites have become a platform for them to boast about their handling skills, their free handling skills, and in that process, a lot of these youngsters, with potential, get bitten and they die a very unfortunate death. So to reduce that, we have started building the capacity of these forest departments in these regions so that they can take care of those activities themselves. Next, please. So we go out to communities. We identify communities. We go out to them. One important thing that we need to remember is if you talk about a general education tool to prevent snake bite or to what to do or what not to do in case of a snake bite, will not work in a culturally diverse country like India. Every region of India has its own demography, has its own character. Every village across India will have a certain character. If we are not smart enough, or if we are not sincere enough to identify those characters and then incorporate our tools, meeting the requirements of those villages, of those demographies, of those cultures, one single source of information, one single cartoon, one single brochure, one single documentary, or one single source of information will not be enough to actually educate these populations to avoid snake bite.
Vishal, you'll have to wrap up in 2 minutes.
Yeah, it's just almost over. Next, please. We do a lot of kids program in schools as well. It helps a lot because in Himachal, there have been a lot more reporting of snake bite since we have started working since the last 3 years. Next, please. We also do some photographic tools to share in social media how bites happen when you sleep without mosquito nets. This is a presentation of how cracks come onto beds and how they crawl under your blankets and how you get bitten if you're sleeping without mosquito nets. Next, please. We also demonstrate how you have to keep your kitchen clean, how kitchens attract rats, and how rats attract cobras. Next, please. So these are the few recommendations that we have come up with, like mapping venom snakes, establishing collaborations, strengthening the clinical management, as well as investing more into education, awareness, and research. Next, please. So till now, all the basic research that has been happening in the country, whether Sunagar's lab, whether CCMB's lab, or whether Tejpur's lab, or whether the South labs, it's now kind of known that India definitely needs specific antivenom formulations which should be regional and not necessarily east, west, north, and south. You can't divide India from snakebite perspective into just east, west, north, and south. You have to consider biogeography. You have to consider where the snake venoms are bearing. Next, please. That's it. Thank you. I'll take questions if there are any.
There's one question. It's from Dr. Mohammed Faiz. Excellent presentation. Is there any bite by greater black crate in Mizoram?
Yes, there are lots of bites by greater black crate in Mizoram, and there are lots of deaths as well.
Vishal,
yeah,
keep up the back-breaking work that you do, and God give you the strength to continue on the way you're doing. Best wishes to you, Vishal.
Thank you so much, sir.
Okay, so we move on to the next topic. The next speaker is Muhammad Anwar, who's an assistant conservator of forests. So why he is here is he's come up with a novel idea. This is taking off from where Vishal spoke. A lot of people actually get bitten handling snakes. So what the Kerala Forest Department with Muhammad Anwar as the coordinator of this project has done is they are training people to actually catch snakes. That is both from the Forest Department and also the general public. It's only certified, that is Forest Department certified snake catchers who are actually allowed to rescue snakes. So this is a very novel and welcome change that has been brought about. So primarily, I would, I mean, it would be very good if it were to spread to other states as well. So with these words, I hand over to Muhammad Anwar. Anwar, please take over.
Sir, am I audible, sir?
Yeah, you're audible. Go ahead.
Good afternoon to all. First of all, thank you, sir, Uh, uh, Actually, this is a great honor for me to be a part of this conference. And actually, it's an attempt by Kerala Forest Department, led by the Chief Wildlife Warden of Kerala, to reduce the number of snakebite emergencies and actual human casualties by providing immediate response to human-snake conflict whenever such situations occurs. So, next. Actually, we all know the number of snakebite emergencies or casualties. There are about 12 lakhs reported snakebite deaths all over India during the last 10 years, from 2010 to 2019. And compared to that, the statistics of the state of Kerala is much less. Actually, there are about 334 reported snakebite deaths in last 3 years across the state. It can be more also. And apart from these 334 casualties, we could save around 1,800 fatal snakebite victims through immediate medical aid. And you know, in Kerala, all big four venomous snakes are present in the state. They are seen everywhere across the state, and also king cobras are also there, and hound-nosed pit vipers are also there, found everywhere in the state. And the problem is widespread across. And compared to many other states of India, the treatment facilities are better than those available in other states. But still, mortalities happen. And even in this modern age, in some part of the state, Kerala, there are traditional snakebite treatments still practiced. And in the recent scenario, there was an incident in Kerala. There was a murder attempted using a cobra and a Russell swiper as a weapon to do the murder. Next, please. Actually, from the view of a forester's eyes, the snakes, all the snakes found in the state and found in India are protected under law, Wildlife Protection Act 1972. And according to Wildlife Protection Act 1972, killing, injuring, or capturing of snakes comes under hunting as per the law. Apart from the protection of the snakes, the law also have provisions to safeguard people's lives. And human-animal conflict, it's the biggest issue faced by the State Forest Department. I think other state forest departments also are facing the same issue. And human-snake conflict is the most common version of a human-wildlife conflict. And for Kerala Forest Department, we have rapid response teams all over Kerala, and we have cultivator rescuers all over Kerala to deal with these conflict situations. But still, we were facing the situations due to untrained and risky rescuers who posed a major challenge for the State Forest Department, who always created difficulties. Next, please. Next slide, please. Actually, in this situation, we plan for a remedy to address this situation. We started planning, and first of all, human-snake conflict was to be addressed, and it was started in 2019. It's not actually the not actually the work done by the State Forest Department alone. It was a joint initiative by the Forest Department, led by the Forest Department, by the Chief Wildlife Warden of the state. And the initiative included experts from many fields and developed a human-snake conflict mitigation SOPs. The initiative was led by the Chief Wildlife Warden, Mr. Surendra Kumar sir. After various meetings, the SOP was prepared, finalized, and implemented. SOP. rescue and release of snakes from human-dominated areas of Kerala by certified snake handlers. Now, after the implementation of the guidelines, only certified snake handlers can handle, rescue, and release snakes from any part of the Kerala. That's the importance of that guidelines. Next, please. Next, please.
Screen Anwar. Anwar. Anwar, are you there? I'm afraid we've lost Muhammad Anwar. Even yesterday, he was in a forest area and he found it difficult to actually send us the slide presentation. Anyway, what they've done is the forest, the state of Kerala is divided into different forest ranges, and the forest department works through those ranges. So the whole state has been divided into areas, and they've been doing this training programs, usually in forest guest houses or in the forest offices, in which they not only train the forest department staff, but they also train others who are interested in rescuing snakes. This again needs a lot of effort, both from the government, and it needs people to actually join in on this. And this has evoked a lot of interest, in the sense that this has been widely reported in the popular media. And the person who brought all this about is Muhammad Anwar. It basically is his brainchild, and he was able to introduce the senior people, that is the Secretary Forests and others, to get the necessary permissions for the same. So 530. So what they've done is 539 forest department staff across the state have successfully completed the training, and here you see a lady actually doing this. Similarly, 318 selected staff functioned as certified snake rescuers and educators. This is more like a training of trainers program, in which the trained staff go on to train others in their vicinity or in their area of work. 620 community workers have been trained in the state so far. 502 of them have been selected as volunteers. And I think we've re-established connect with Anwar. Anwar, go ahead, please.
Sorry, sir. There was a network issue. Can you please share the presentation?
Yeah. Can you see it on the screen?
No, sir. It's not coming.
A second. It'll just come in.
Yeah, it has come.
You can go ahead. I tried telling them. I tried filling in for you unsuccessfully, I think. Go ahead, Anwar.
Yeah. So we could, as part of this, we could train around 820 people, rescuers. They are now available across the state. And we are having a fully functional mobile application also. That's called the SARPA, Snake Awareness Rescue and Protection Application. That is used by all the rescuers we train, and a backend system to monitor all the snake rescues and release in the real time. Even the chief wildlife warden and the junior officers can see the data of the rescue and releases happening all over the state. And in the mobile application, we are having all the list of all the hospitals in Google Map to ensure the immediate medical aid is available for a snakebite victim. Next, please. a centralized system, previous one, sir. Centralized system to manage and monitor all snake rescue calls, rescuers, and all are coordinated through this SERPA mobile application. The system is controlled and monitored by State Forest Department. Many inputs are there. We got for the support from Wildlife Trust of India and other agencies. Valuable data about human snakebite conflict is collected on a daily basis. So after 1 year or even after 6 months, we will be available with a data of the pattern of snake-man conflict and which all our species are creating conflict. And by monitoring through the SERPA mobile application, we are able to control the illegal activities happening in this field. Next, please. So our way forward includes ensure immediate relief during snake-human conflict and to minimize the mortalities on human side and snake side, and to educate general public, especially the rural public. And the third one is to help other states. Actually, decisions have been taken to replicate this model in other states by Ministry of Environment and Forests. So we will be providing assistance for that and provide support for the scientific community in anti-venom research. And that's all, sir. And sorry once again for the technical issue of network.
So nice talk. Let's see if there are any questions on the chat box.
Yeah, sir, sure.
Yeah, there are a few questions. First is there any remuneration for the trainees? This is from Professor Somnath Das. Is there any remuneration for the trainees?
For the trainees, initially it's a completely voluntary activity, but we are having discussions with the LSGD, local self-government department, and through the gram sites, the actual expense, petrol expense, vehicle expense, like that, it will be reimbursed in recent future. And we are arranging for insurance coverage for the voluntary rescuers. It's actually on the implementing stage. At present, completely it is a voluntary service.
Okay. There is one more interesting question from Priyanka. Dear Anbarji, excellent initiative by Kerala Forest Department. Will the Baba Suresh free handling stop now that the Forest Department is involved in spreading awareness?
So actually, we have conducted 2 trainings, phase 1 trainings for the Forest Department staff only, and phase 2 training for the volunteers, general public, interested public. So phase 2 training was open for every interested people, but he was not an applicant. Baba Suresh could not attend the phase 2 training, so he will not be certified. And once this guideline is implemented in the state, only certified snake handlers can rescue snakes in any part of the state. Nobody else can do it.
There is one more question from Vishal Chandra. I think I'll leave the question open for others to answer. Will venoms and tissue samples from Kerala be officially and legally available for analysis through this endeavor?
That can be contacted through the Chief Wildlife Warden of Kerala. He is the competent authority to issue permission for that.
I think due to time constraints, we will move on and we'll take questions again if you have time.
But from all the discussions in the morning, ours is more in the theoretical realm, in the sense that it may take years together for what is discovered by science to come into practice. What you're able to do will bring about immediate effects, in the sense, for sure, that human-animal or human-snake conflict would come down through your efforts and through the efforts of your department. Keep going the way that you are. Thank you.
Yeah, yes, sir. Thank you so much for this opportunity, sir. Thank you.
So we move on to the last session.
It is the graciousness of Dr. Jaydeep Menon that he has given me this honor of introducing our final speaker for the day, Professor David Worrell. As the cliche goes, last but not the least, Professor Worrell is, of course, the last word on snakebite and snakebite management and he's known all over the world. Wherever somebody is treating snake bites, he would have heard the name of Professor David Warren. And if somebody says he has not, then there is suspicion whether he's actually managing bite at all. Professor David Warren is, of course, legendary. He has been in Oxford. He has created the tropical medicine unit there. And I have had the pleasure and privilege of meeting Professor Warren on several occasions. First time, I think, right here in our own institute, way back in 2003 or 2004. And as always, I've always been mesmerized by his lectures. I'm sure he's going to do that in this particular session also. It is but fitting that he is at the end of the program, because I'm sure a little bit of mental fatigue that may have set in the audience will be dispelled by this presentation of Professor Warren. We are all eagerly waiting to hear him speak on future hope for snakebite victims. And when Professor Warren says there is hope, then we all have to be really positive about the issue of snakebite management. Professor Warren, the stage is all yours.
Well, thank you very much indeed, Dr. Jaideep. I'm just trying to get my screen right here. I want to share screen. Can you allow me to share my screen, please, Dr. Jaideep?
Yeah, it's permitted. It's been allowed, sir. You can go ahead and share your screen.
Right. I'm just not getting the right.
If you want us to, we can do it for you from here.
I'm not at the moment. I'm not able to get my screen. I don't know what's happened.
Can we do it from here?
Yeah.
Perhaps I could try again now, share my screen.
Please do so, sir.
No, it's not allowing me to do so.
We are seeing the screen, but not the PowerPoint.
We are seeing you, sir, but not the PowerPoint. Can you just open the PowerPoint? You've got to open the PowerPoint.
Yes, I have opened it, but it's not working. I think you'll have to project it for me, please, Dr. Jaideep.
We'll do it from here.
I'm sorry about that. I haven't had this technical problem before. So I'm extremely grateful to the hosts for allowing me to join this meeting, and I've been fascinated by the excellent talk so far this morning. As usual, when I have anything to do with the Indian snakebite and snake community, I've learnt an enormous amount. So my title today is really to publicize in a way a marvelous charity based, run by some friends in Kolkata. Next slide, please. So this is Future Hope, which rescues orphan children in Kolkata. So I'd like you all to know about them. But the point about this group of delightful children is to remind you that in the last 20 years, according to the recent findings of the Million Death Study, 325,000 Indian children have died of snakebite. That's 28% of the total deaths from snakebite in India during that period. So we mustn't forget that children are major victims of snakebite. Next, please. So I want to quickly cover a few of these areas today, which I regard as the future hope for snakebite victims. So their hope for a better future, for better treatment, rests on improvements in all these different areas. Next, please. We've heard a lot about community education already today. Very impressive what's being done. Next, please. How to avoid and coexist with dangerous snakes to reduce the risk of bites. I think we're all aware of the principles here. So awareness of dangers and particular environments and times of day, times of seasons of the year, and how to behave appropriately if you or a colleague is unfortunate enough to be bitten. Next, please. First aid and so on, and confronting the problem of traditional treatment and traditional therapists. Next, please. So here are some examples from Myanmar. At the top, a township committee, snakebite committee, given the task of trying to decide how to reduce the risk of snakebite. And then the bottom two pictures from my Myanmar colleague, Dr. Utung Pei, about developing lightweight protective equipment to protect particularly agricultural workers. And as you can see, putting them to the test here, using with the help of volunteer Brussels Vipers. Next, please. Next, please. I think as far as disseminating community education is concerned, we must explore all available channels. And we must test the acceptability of interventions before we try to promote them. And one obvious example, the top here, is during the ploughing and the transplanting season in the rice fields, which are a major source of snakebite in many Asian countries. It's clearly impracticable for these farmers to wear boots, even if they have mechanized transport. But in the lower picture there, you see during the harvesting season, where it's dry and where the peak of bites occur, certainly in Myanmar, boots are practicable. So we must try and encourage agricultural techniques that offer lower risks to the farmers, one of the key target populations. And we must test the effectiveness of proposed interventions before we try to implement them. And again, Dr. Tung Pei in Myanmar has found that the boots, the lightweight boots he developed, are acceptable. Also, to integrate prevention of snakebite prevention with other diseases within the health system. This is clearly going to improve the cover and power of any intervention if you can argue, if you can show evidence that it will protect you from other diseases such as vector-borne diseases and all those many causes of skin abrasions and foot injuries. Next, please. So it's important to promote, previous slide please, to promote an effective first aid method. Next. Next, please. Yes, this one. And currently the first aid method which has most going for it is the compression pad immobilization method. It's very simple. You apply a pad of almost any material that happens to be available directly over the bite site. You bind it on very tightly with a non-elastic bandage and you splint the limb to achieve immobility. Next, please. Next, please. This is a comparison of the pressure pad. Next. 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 Sorry, back again. Sorry, this is difficult because I'm not controlling it myself. Yes, thank you. Please stick on this slide. This is a comparison between these two very highly publicized first aid methods for snakebite. On the left, the pressure pad immobilization, and on the right, the longer established pressure bandage immobilization method, the so-called Sutherland wrap, which we heard referred to earlier this morning. And as you can see, under all categories, the pressure pad is much more realistic. It's easy to teach people to use this method. The materials are readily available. The dangers are negligible. And the isotope labeled mock venom studies in humans and volunteers show that it's effective in restraining venom-sized molecules. And most important, there are two small field studies, which I'll show you briefly, which show that this method is effective in restraining venom molecules from leaving the site of the bite, as long as the pressure pad is applied. Compared with those advantages, the pressure bandage immobilization method is really pretty impracticable. You've got to use heavy-duty elasticated bandages, which are expensive and rarely available. It's a very difficult technique to teach effectively, because people tend to apply it too tightly. And there's, apart from anecdotal cases, which are individually pretty impressive, I must admit, there's really no clinical evidence. Struan and Sutherland chose not to test this method clinically. Next, please. And here's the evidence in two parts from my colleague, Dr. Tungpei in Myanmar. You'll see in this chart, the time is along the bottom and the venom level measured by a sensitive enzyme immunoassay in the bloodstream is in the vertical there. And you'll see that in 15 patients, as long as the pressure pad was applied, there was virtually no release of venom into the general circulation. But once the pad was released, the venom levels rose. Next, please. This was followed up with a second smaller study in 9 patients with the same result. So this method does seem capable of restraining venom molecules. In this case, it was Russell's viper in Myanmar in the area of the bite by compressing veins and lymphatics. Next, please. So training medical staff is terribly important. We have to include snakebite in the curriculum. And remember, the people who look after snake bites, depending on which country you're in, anyone from qualified doctors to nurses, midwives, health workers, pharmacists, and so on. And it's important to incorporate teaching in national guidelines and to include questions on snakebite in exams. That is the ultimate test that you're really taking snakebite seriously. And here, next please, and here's some examples of teaching in Myanmar and in bottom left in Little Flower Hospital, Angamali, where I've had links since the 1970s. It's a marvelous hospital. And I'm grateful to my colleagues from Angamali for inviting me today. So bedside teaching, there's nothing like it. And teaching enthusiastic young medical students and persuading them that snakebite is an important aspect of acute general medicine. Next, please. Now, I'm very keen on doing clinical research on snakebite patients. And just one historical reference here, this is an ancient English poet called Alexander Pope, and he made this famous remark, "The proper study of mankind is man." We can get a certain way looking at mice and animal models, but ultimately we really have to do clinical studies of human patients. Next, please. Some venom effects are extremely different, species related, comparing humans and mice. And I'll give you an extreme example of that in a moment with the cobra venom. There's no substitute for prospective ethical investigation of human snakebite cases. And we can study mechanism of life-threatening dysfunction using expanded range of techniques, including enzyme immunoassay to confirm the species and to measure the concentration of venom antigens in the bloodstream. And also to remember the many neglected target organs. I mean, one is the myocardium. It's already been mentioned this morning in relation to the Rajasthan Naya population. Certain key processes such as inflammation and toxins, which you probably can't see there. My example is going to be atrial natriuretic peptides, which are found in the venoms, for example, of many of the Asian kraits. Next, please. And here's one extreme example, an African spitting cobra. If you test this venom in the laboratory, mice die of neurotoxicity, of convulsions very rapidly. Humans don't develop any neurotoxic signs at all. But in human patients, the venom exerts a terrible effect, causing local necrosis, which is very rarely has fatal complications, but far more often leads to permanent physical impairment. Next, please. Species diagnosis is extremely important. This has been emphasized by previous speakers this morning. It's an essential basis for defining which are the common biting and envenoming species in the different areas of the country. This is a basis for designing national polyvalent antivenoms, and we've heard an argument for regional antivenoms given this morning. I think the previous speakers already made this point very clearly. To make a species to have a species diagnosis empowers you to provide optimal treatment. And this applies even if you have a polyvalent antivenom. You must still be prepared for the individual complications associated with the species, the venom that's involved in your patient. And this is very important in carrying out any clinical research in countries, certainly countries like India, but there's only a very few countries in the world where there's only one venomous species, where you can ignore the differentiation of species identity. And finally, very important, this will provide a basis for developing reliable clinical phenotypes as a basis for algorithmic and syndromic diagnosis and treatment. Very often we have to rely on a syndrome, identifying a typical clinical syndrome, since if we don't have any other means of diagnosis. Next, please. Now, here are the different methods for making species diagnosis. In a way, the ideal is expert identification of either of the snake specimen responsible or of a photograph of that specimen. Increasingly, smartphone photographs are available. Then there's qualitative and quantitative enzyme immunoassay. There's only one commercially available example of this worldwide, and that is the Australian so-called VDK, Venom Detection Kit. But I would warn you that there have been a lot of problems associated with the use of the VDK in Australia, and getting a positive result on a wound swab does not prove that that patient is envenomed. It only means that the patient has been in contact with a particular species or genus of snake and has left some of its venom on the surface at the site of the contact. The indirect identification of patients by patient or witness, we've already seen examples of this using museum specimens and so on, can provide a useful clinical clue, but it's unacceptable for research purposes. Next. Next, just to remind you, the only commercially available test in the world. Next, please. So my current take on this in India is that immunodiagnosis is an essential research technique for doing clinical research on snakebite. And I've still to see any publication from India in which enzyme immunoassay was used to confirm species diagnosis. But at this stage, I don't think it's an appropriate priority for routine clinical use. Next, please. Antivenom, India has a glorious record of developing antivenom and using it for nearly 100 years now. Here's a historical photograph from the Kasauli Institute back in 1943. And we've already been, thanks to Dr. Kartik Sunagar, we've been through the process of producing an antivenom. Next, please. Here are some of the key ways of improving antivenoms. And I think our priority here should be to improve polyclonal polyspecific antibodies raised against whole venoms. There are other experimental clever techniques, but I think that this should be our priority, is to go with the traditional pattern, but to improve it. We've heard plenty of arguments already today about how we should redesign our antivenoms according to new information about the diversity and clinical importance of herpetofauna, that is the pattern of venomous snakes in each part of the country, and how we should reconsider the choice of immunizing venoms, not just going from venoms from just one part of India, but bearing in mind the variation, but both within species and between species in different parts of the country. Certainly there's a need to improve refinement to try and reduce the incidence of adverse reactions. And we can also reconsider the choice of animals. And there's a lot to be said for camelids, camel-like animals. It's important, finally, to validate the safety and effectiveness of antivenoms in clinical trials. There is no other way of confirming safety and effectiveness of an antivenom, except by doing a clinical trial in patients. Next, please. Next, please. Just to remind you that India has a great deal of expertise in the area of camels. This is my friend Dr. P.D. Tanwa up in Bikaner in Rajasthan, where there's an institute of camel care. At the bottom, you'll be familiar, many of you, with the unique classes of immunoglobulins in camel blood, the IgG2 and IgG3. And these are whole heavy chain, next please, heavy chain antibodies with a unique VHH single domain antibody binding site, which is, has enormous theoretical advantages as for future antivenom production. So I'm keen to encourage your country to make use of its skill and experience with camels in exploring this. Next, please. Now about one of the most exciting areas of growth and future hope for snakebite victims is the use of ancillary treatments, drug treatments, using repurposed enzyme inhibitors that are already being used and found to be acceptably safe in human patients. Next, please. Here's a rather prohibitive table, but since this session is being recorded, you can look at this afterwards, I hope, giving some examples of the enzymes that we can inhibit in treating snakebite patients. The most familiar, because it was an Indian discovery, is the use of anticholinesterases from Dr. Banerjee's work in the 1970s. This is prolonging the life of endogenous acetylcholine at the neuromuscular junction and could produce a very useful, if short-term, improvement in neuromuscular transmission. That's well known. But these other compounds have not been tested yet in human patients. They target metalloproteinases, serine proteases, phospholipases A2, and hyaluronidase, and there are other examples as well. Probably the most exciting and the one you're most likely to have heard about is varespladib, which inhibits not only venom, but also tissue phospholipases A2. And that might be important. I mentioned the inflammatory process a few minutes ago, because varespladib might also damp down the deleterious inflammatory response to envenoming in humans. So watch this space. It's going to be very exciting. Next, please. Surgical treatment. This is a controversial area which I'm very exercised and anxious about. I've listed here some of the areas where surgical colleagues provide us with essential help. Draining wound abscesses, aspirating tense blisters, but don't deroof blisters because that exposes a large area of vulnerable dermis to infection and damage. Debridement or even amputation of necrotic tissue to avoid allowing the growth of dangerous organisms in the necrotic tissue, and a particular anxiety have about necrotizing fasciitis, which I believe is occasionally being misdiagnosed as envenoming, as an effect of envenoming. And as we all know, or we physicians know, necrotizing fasciitis is a disease where we need the urgent help of surgical colleagues. Skin grafting, and a main argument of mine, is to try and discourage fasciotomy. We've got to encourage restoration of function in the bitten limb. So here are some examples. There's a wound abscess that needs aspirating. Next, please. Tense blisters and the results of skin grafting. And bottom left is an example of necrotizing fasciitis, which could easily, I think, be confused with envenoming and perhaps not treated appropriately. This is an extreme medical emergency, as you will all know. Next, please. Next, please. Now, fasciotomy. Here's an ancient Japanese picture of fasciotomy occurring without anesthetic in a heroic Japanese general. Well, it's not quite like that these days. Next, please. the problem here is that surgeons may be misled because snake-bitten limbs sometimes look just like limbs with compartment syndrome. They have all the clinical signs. So here are the 5 Ps of compartment syndrome, which will often be recognized by our surgical colleagues. So pain, pallor, pulselessness, paresthesia, and paralysis. These are compatible with snakebite, with severe local envenoming, as in this example from Thailand, from a Malayan pit viper. This apparently pulseless limb, in fact, the pulses were present and were detectable by Doppler probe there. And I want to emphasize that there's been a lot of discussion about the role of fasciotomy in snakebite limbs over the last 2 or 3 decades. And international expert surgical opinion has now moved very strongly against fasciotomy in snakebite victims, except in a very few highly selected cases. Next, please. Fasciotomy should never be carried out until antivenom has been given to neutralize the effects of circulating venom. Hemostasis has been restored with antivenom, speeded perhaps with blood products. And you must have demonstrated that the intracompartmental pressure is really raised and is raised in a sustained way over at least an hour. Because as I've just pointed out, the clinical signs can be very misleading. And there's a warning here: compartment syndrome is potentiated by pressure bandaging and by excessive limb elevation. And unfortunately, experimental evidence in animals suggests that muscles that have been sufficiently envenomed to raise significantly the intracompartmental pressure are non-viable. So the results of fasciotomy will be disappointing. Next, please. Fasciotomy itself, of course, can produce considerable morbidity and prolonged hospital stay. Some surgeons complain to me that they don't have any equipment. They can't afford the Stryker apparatus, top right here. But in fact, you can make your own manometer. Here's an illustration from an early paper showing how simply you can construct a manometer for measuring intracompartmental pressure just using a syringe and a mercury manometer. And bottom left is what I made myself when I was working in Thailand a few years ago, using a syringe pump and a saline manometer. It's easy to measure intracompartmental pressure without, if you can't afford the Stryker machine on the right. And I just wanted to show you 2 examples where clinical impression suggested compartmental syndrome. For example, the top one, very tense, swollen, cold, cyanose, pulseless limb, but you'll see that the pressure we measured with the Stryker was only 12 millimeters of mercury. And bottom one, a patient from Dr. Joseph K. Joseph's service in Angamali with Russell's viper bite. Again, a cold, very tense, painful, tender limb. Next, please. But you'll see that the pressure with the Stryker apparatus was 45, which is above the threshold for fasciotomy in many services. But the important point here is over the next hour, the pressure fell below the threshold, with just making the patient comfortable as a result of treating them with antivenom. Next, please. Rehabilitation has been ignored in the past, and one can quite understand why. It might be regarded as a luxury in many very busy hospitals in rural areas, but it's important to encourage early physiotherapy, starting while the patient is still in the hospital, to restore function. And it's crucial, remember that many of our patients are agricultural workers, and they're absolutely dependent on their physical ability. And you may even need to fit a prosthetic limb. And here are 2 examples: a little girl on the right who had a spinal artery thrombosis resulting in spastic paraplegia from a Russell's viper bite in Sri Lanka, making the early steps of rehabilitation. And on the left there, a patient from South America who's had an amputation and will have to progress through use of crutches, and we hope eventually being fitted with a prosthetic limb. Next, please. Now, advice when the patient leaves hospital, as we know, as experienced doctors, we don't just wave them goodbye and say good luck. We have to explain what's happened to them and reassure them and plan a follow-up, ideally. Warn them, for example, about late reactions to anti-venom. The serum sickness type reactions come on after 5 to 10 days, and that may be after they've left hospital. Encourage contact in case of new and unexpected symptoms. Encourage them to continue exercising the bitten limb. And most important, and most often forgotten, we must educate them about how they and their family and neighbors could prevent future bites. Next, please. And it's ideal if you can send them out with a simple brochure. And here is a brochure in Myanmar language, in Burmese, couldn't be more simple, emphasizing the importance in future of using a light and a stick after dark and wearing proper foot protection. Next, please. So I'm very grateful to you all for listening to my talk so far. Just to summarize the points, we have to strengthen, in order to give a better hope for our snakebite patient victims, we must strengthen community education. We must train our medical staff better at all levels of the health service. We must promote more prospective clinical studies rather than relying too heavily on the excellent laboratory work we've seen presented earlier today, remembering the proper study of mankind is man. There is no substitute for studying human patients. Treatment must be based on species diagnosis. In fact, I think the term viper bite should be banned in India. And we've already seen that very well illustrated so far this morning in these excellent talks, particularly from the Northeast. But I believe that immunodiagnosis, although it's essential for research, is not practicable for routine clinical practice at the moment, although the presentation earlier this morning by Dr. Tarun shows what exciting developments there are, technical developments there are towards easy immunodiagnosis. So our patients need access to, next please, more effective and safer antivenoms, and Dr. Kartik Sunagar has given us a very nice survey of what should be done there. I've given you the exciting prospect of new ancillary drug treatments, and I've been very cautious about surgical treatment and emphasized how rehabilitation should be continued, and the patient should be followed up after they leave the hospital. So thank you again very much for your attention and for this invitation. I feel very privileged to be admitted to an Indian meeting, and I have learnt an enormous amount from today's experience. I look forward to the other 2 days of the meeting. Thank you all so much.
Thank you, sir. Excellent talk as usual. I think there are a couple of questions on the chat box.
Yeah, the first question is from Kartik Sunagar. Thanks very much for the excellent talk, Professor Farrell. While I agree that the clinical research will convey the final verdict, how easy is it economically and strategically to rely on it for testing the effectiveness of antivenoms against the diversity of snake populations we have?
I'm sorry, could you repeat the first part of the question? I didn't quite clear. Thank you very much for the question, by the way, but could you repeat the earlier part?
Sure. While I agree that clinical research will convey the final verdict, how easy is it economically and strategically to rely on it for testing the effectiveness of antivenoms against the diversity of snake populations we have?
That's an extremely relevant and shrewd question, if I may say. We all know how expensive research is and how difficult it is. It's increasingly difficult to do clinical research in all parts of the world today. There's been a proliferation of various regulatory authorities and so on. So it's a major undertaking to contemplate any sort of clinical research. And I don't believe for a moment that we will be able to test all the new antivenoms against all the available species of venomous snake, for example, in India. But I think it's very important at least to have one or two key examples, and I would prioritize Russell's viper, particularly in India, where we need to have at least one or two studies in which we've tested the validity of the sort of predictions made by preclinical testing, that includes mouse studies and antivenomics, which is this very exciting new way of looking at the immunorecognition by antivenoms of the vast diversity of venom molecules. We need to be able to test in at least one or two cases how appropriate it is to rely clinically on that sort of information. But I do agree with you totally. It is totally impracticable for us to attempt to do clinical studies of all antivenoms against all types of envenoming. But we do need one or two prioritized key studies.
I'll take one more question. That is from PC Rajiv. He's asking about any role of hyperbaric oxygen therapy in snakebite.
Well, hyperbaric oxygen is a very interesting idea for devitalized tissue of very many different causes. And there are always enthusiasts for hyperbaric oxygen. For me, it would not be a priority for a snake-bitten limb. I think it's very difficult to apply in the areas where we know snake bites are most common. And I'm not impressed really with the results, the few anecdotal cases of the use of hyperbaric oxygen. In principle, theoretically, it sounds excellent because you're dealing with devitalized ischemic hypoxic tissues. But I don't think it should be our priority. I think we should go for early antivenom treatment, for expert surgical treatment, early debridement and reconstructive surgery. I think they're far more likely to improve the ultimate prognosis of our patients than an expensive and exotic and impracticable thing like hyperbaric oxygen. But thank you for the suggestion.
We've unmuted. A whole lot of you all have been unmuted. If there are any questions, you all could please ask, because this is the last talk. Professor Kinney, Professor Vishwanath, Dr. Joseph, Dr. Patel, Dr. Punde, Dr. Sudhakaran, Priyanka, Dr. Sharma, all of you all have been unmuted.
Sir, is there any role of calcium gluconate in crate bite management?
I don't know of any basis for that. Calcium gluconate was popular at one stage in treating neurotoxic spider bites, for example, in North America. But for crate bite, I wouldn't regard that as a priority. I would warn you, by the way, of this unusual complication of hyponatremia, sometimes lethal hyponatremia following envenoming by some crates. It seems to be relatively common outside India, but has not yet been reported, I think, in India. But please be aware of that if you're thinking of electrolyte treatments. Thank you, Dr. Punde.
Thank you, sir.
Dr. Joseph, anything to add? You have to unmute yourself. You have to unmute yourself.
Hello, sir. Any role of forced alkaline diuresis in Russell Viper patient?
That's from DC Patel, sir.
Yes, sir.
I'm sorry, any role for?
Alkalinizing dialysis.
FAD, forced alkaline diuresis.
Ah, yes. Well, I mean, this is a strategy used, I know, in some cases of poisoning. We used to use it in aspirin poisoning, for example. I don't think there's any basis for that in Russell's viper envenoming. Of course, it's crucial to watch for the early signs of acute kidney injury. And if that can't be combated conservatively, then to move towards renal replacement therapy. And you've got various options there, including simple peritoneal dialysis. But no, I don't think alkaline diuresis would be appropriate. But thank you for the suggestion. It's important to keep thinking of these different things.
Professor Warren, it was a wonderful talk as usual. Thank you very much for again giving us new ideas for treating snake bites, especially the last part of the snake bite victims, physiotherapy. That's also we are not doing it properly actually. So thank you very much for that suggestion, and definitely we will be able to do much better for these patients.
Thank you very much, Dr. Joseph, and for all you've taught me at Little Flower Hospital during my many visits there. Thank you.
Dr. Warren, I have a question. Thank you for putting a lot of things in perspective for all of us. The Americans are still fond of doing fasciotomies, especially for the crotolid bites. So should it be totally banned? Because I know there are a lot of legal cases which come out from their forensic herpetologists in court cases because these led to amputations and other things. What is your opinion about that?
Well, thank you, Dr. Paul. Yes, you're absolutely right. America has been the hotbed of fasciotomy. In fact, there was a famous Thomas Glass Jr. in San Antonio, Texas, and he not only attacked the wound site, he did extensive wound excision to remove the venom depot. He then proceeded with these long S-shaped incisions, pretty well from chin to apex, as it were. Well, this is the interesting thing, that if you review the literature now, there have been 4 or 5 reviews by experienced, very reputable North American surgeons, in which they've looked at the evidence and they've come out against the use of fasciotomy for pit viper, for rattlesnake bites and so on in the United States. And that's impressed me very much. And it's, in fact, the best literature on reviewing fasciotomy and snakebite in recent years has been from the United States. And as I said in my talk, international opinion has now moved very much against fasciotomy, except for very few exceptional situations.
Right, thank you.
Anybody else wants to add anything? You all could just unmute yourself and speak. Any comments at all?
Wonderful first day sessions, Jaideep, and all the speakers made wonderful discovery. I'm extremely happy people are coming up with new enthusiasm and new ideas. And of course, I would like to thank David for giving a wonderful talk in the end to put the icing on the cake. Thank you, David. And thank you all for organizing as well as wonderful talks. Thank you.
Thank you. Thank you very much.
So thank you very much, Dr. Jaideep, Dr. Pillai, for that excellent conduction of the meeting. It went on very well.
I just have one question, sir. I'm Priyanka here. Dr. Warren, thank you for your excellent presentation as usual, sir. And I had typed my question in the chat box here. When I go on my field work, I see a lot of clinicians in India who make incisions near the bitten area, and they flow the blood out. Despite pointing this out many times with experts, what is the way out? Can WHO write to the institutions where these clinicians work, and is there a way to sort of get this corrected? This kind of treatment.
Well, many thanks, Priyanka. Clearly, this is this is the worst one of the worst possible things to do with a snakebite case, because there's the risk of introducing infection into causing local injury, and also to allowing prolonged bleeding if the patient's got an anti-hemostatic disorder. But about 100 years ago, when I was a Boy Scout in England, I was taught to make an incision at the site of a bite. We only have one venomous snake in England, the venomous one, the adder. So I'm afraid that this is very deeply embedded in snakebite treatment mythology, but we have to combat it. Certainly WHO in its guidelines, which I'm afraid are insufficiently disseminated and used, comes out very much against any interference, local interference at the wound site. And I think it's really going to be much more powerful if it comes from your national and regional organizations in India. If you make it quite clear that any sort of interference is dangerous. And I'm still seeing cases to review where terrible consequences occur, including, I mentioned this business of necrotizing fasciitis, which is a rapidly evolving, highly fatal bacterial infection. There are numerous cases where this has been introduced through the use of non-sterile incisions made at the bite site. So I totally applaud your stand here, Priyanka, but WHO has made its opinion known about this. I think this should be followed up, as I say, nationally and regionally in India.
Hello. I'm Professor Shomnath Das from Kolkata. Sir, I just want to know one thing, that what is the role of plasmapheresis in treatment of viper and bite? The reason is that actually we had saved the case. Maybe it can be due to that plasmapheresis or whatever else, especially in case of a children who was actually a 5-year-old boy. It was done at one of the hospitals at AETCM. So I just want to know what is the role of plasmapheresis, especially if it is done early before the tissue fixation has been occurred in the snake bite cases.
Well, there are two aspects. Thank you very much, by the way, for raising the question of plasmapheresis. It's very controversial. There are two aspects. One is to use it generally, non-specifically, in the hope that you will dilute the venom load. And I would be totally against that. I think there's absolutely no grounds for that at all. But there's a second, more persuasive application here. Now, you'll be aware that a major cause of acute kidney injury in snake bites, many different species of snakes, is microangiopathic hemolysis or thrombotic microangiopathy. The mechanism here is that there's damage to the vascular endothelium, which in turn damages circulating erythrocytes. So you will see the schistocytes, the fragmented red cells in the circulation. This is often associated with profound thrombocytopenia and acute kidney injury, which is remarkably refractory to renal replacement therapy. And this has been increasingly recognized. And it's common to envenoming by a very large range of species, including the Australian elapid snakes, but vipers in many continents. And because of the analogy between this and thrombotic thrombocytopenic purpura, people, and I'm afraid, sorry, Dr. Joseph, particularly nephrologists, have started to recommend and to use plasmapheresis in cases of acute kidney injury in which there were circulating fragmented red blood corpuscles. And I won't go into more detail about this. This is an unlikely hypothesis. And I'm very skeptical about the anecdotal reports that have been published so far. I think that it's such an expensive and potentially dangerous treatment that it should be tested clinically and critically before it should be recommended generally. So for the time being, to answer your question absolutely clearly, I would not use plasmapheresis at all in snakebite envenoming, but there is this interesting idea of the use of plasmapheresis for microangiopathic hemolysis if the pathogenesis is shown to be similar to those cases of thrombotic thrombocytopenic purpura or hemolytic uremic type syndrome, in which there are autoantibodies involved.
So thank you all. I think we close for today. It's been a good learning experience, starting with Professor Faiz from Bangladesh and ending with Professor Wardle from England. And we had a whole lot of youngsters also in between with exceedingly interesting research topics that they presented. So we end the day one session now and hope to meet all of you all again on Tuesday, same time. All of you all take care and stay safe.
Thank you. Thank you.
Oh.